and welcome to the Heads Up Community Mental Health Summit. I'm Jo DeVries, FOF founder, and I'll be your host and co-facilitator for the next day and a half. Thank you so much for joining me. I feel so honored to be here with you all and leading this vitally important discussion. While this is a virtual event with people from across Canada and beyond, I'd like to acknowledge that this program originates on the unceded territory of the Syilx people in the Okanagan region of British Columbia, Canada. I'd also like to thank our amazing sponsors and supporting granting organizations. There's no doubt that without you all, we wouldn't be here. I'm so excited about today's session, which is called Mobilizing Systemic Change for Better Mental Health Care. But first, I'd like to share a bit about FOF and our vision for the future. We see a time where people from all sectors, ages, cultures, abilities, and genders communicate and then collaborate to confront our most pressing community challenges and to rally around our best opportunities. To that end, we host events such as our Building Sustainable Communities Conference, Community Innovation Lab, Real Change Sustainability Film Fest, and EcoBlast Kids Camp. We're thrilled to embark on our latest program, the Heads Up Community Mental Health Summit and related podcast. Both combine science with storytelling to explore various mental health issues with people from all walks of life. Before introducing my co-facilitator for this session, I'd like to share the primary drivers for what I'm hoping will grow to be FOF's Heads Up movement. First, the numbers don't lie. Statistics show that at least half of Canadians over 40 have experienced or will develop a mental illness. And from a provincial perspective, in BC alone, about 800,000 people currently struggle with mental health challenges or addictions. And before the province of BC introduced its groundbreaking Pathway to Hope mental health roadmap in 2019, more than 85,000 children and youth in BC had been diagnosed with mental disorders, and only 1/3 of them were getting the treatment they needed. And can you guess what the number 15 represents? That's how many Canadians will die by suicide over the next day and a half of the summit, and the number of families whose lives will be tragically changed forever. And what would happen to the numbers if we do nothing more than we're doing right now? The Mental Health Commission of Canada predicts that 9 million Canadians would live with mental illness by 2040, and that the annual financial burden in the next 20 years would rise from 55 billion today to more than 300 billion. Grim statistics for sure, but at FOF we believe that change is a collective opportunity as well as a shared responsibility, and that communication and collaboration among people from all walks of life will ensure the innovation that leads to healing for individuals, families, workplaces, and communities. Another reason for Heads Up is that its time has come. Dialogue about mental health is a natural extension of the conversations about sustainability we've been having with communities for the past 15 years. In fact, there isn't a measure of community sustainability, be it social, cultural, environmental, or economic well-being, that isn't greatly impacted by mental health. And then there are the mental health impacts at all scales of COVID-19. Uncertainty combined with altered routines, financial pressures, social isolation, addiction, misinformation, and information overload is causing higher levels of stress, fear, sadness, loneliness, anxiety and depression, substance use, and suicide. Heads Up also bears witness to my own history with anxiety, depression, and disordered eating. I know how debilitating mental illness can be, but I also know that healing is possible. And I've learned that being vulnerable about my challenges has not only helped my healing, but that of others who know my story. Which leads me to the final and likely most compelling argument for Heads Up, and that's the power of other people's stories to mobilize change. Take Janine Rayburn, a young mother in Kelowna whose almost 9-year-old son attempted suicide in 2017. Janine and her family have experienced a level of trauma that most of us can't even imagine, let alone know how to deal with or fix. You are here today because of Janine's strength, courage, determination, and hard-won wisdom, which motivated me to initiate a community-wide discussion about mental health and how we can all step up to that plate. Janine will share her story tomorrow morning when I dedicate that session to her, her son Lyndon, and their family. Today, I'm dedicating our session about systemic change to my mom and maternal grandmother, who I never met because she died by suicide when my mom was just 8 years old. It's a tragic story, but one that also shows how our mental health care system has changed for the better over the last 90 or so years. In 1928, my mom and her siblings arrived home from school one day to find their mother dead. Given the stigma associated with mental illness in those days, they were told never to speak of their mother's suicide again. Among other things, they heard that they could be put into a mental hospital because their mother had been mentally ill. They were even told that if their mother's past was known, they wouldn't qualify for higher learning when they got older. My mom, who wanted to be a nurse, took that to heart and never spoke of her mother's death again, even after decades of marriage to my dad, with whom you could talk about anything. It breaks my heart to think of the anguish and hopelessness my grandmother felt and the secret shame, pain, and grief my mother carried for all those years. It's also mind-boggling to know that if my grandmother had sought help in that era, she would have been subjected to the well-meaning yet brutal mental health facilities and treatments of the day. She probably would have been admitted to a prison-like mental hospital like this one, where no standards or legal protections existed. Depending on her illness and the threat she posed to herself and others, she might have been subdued by devices such as a restraint sheet or a straitjacket. Doctors might have included her in experiments for what they thought were promising treatments. Hydrotherapy, for example, where patients were submerged in very hot or ice-cold water for prolonged periods of time. Or insulin shock therapy and chemically induced seizure therapy, which doctors thought might reset people's brains to normal function. Or malarial therapy, where they injected malaria-infected blood into patients' brains, thinking the induced fever would cure some types of mental illness. My grandma might have also been considered a candidate for more drastic measures, such as trepanation, where they'd bore a hole in her head, or a lobotomy where they'd sever connections in her brain's prefrontal cortex. Thankfully, these treatments belong to mental health care's tortured past, having been continually replaced by kinder and more scientific approaches. Having said that, however, we still have a long way to go. 100 years from now, people will look back on today's mental health care system and wonder how we could have been so clueless. I hope so, because that will mean great progress has been made. But for now, let's talk about where we're at today and how we can transform our mental health care system over the next number of years. For help with that, I'd like to introduce my co-facilitator for this session, Nicholas Waters, who's Director of Access to Quality Mental Health Services with the Mental Health Commission of Canada. Welcome, Nicholas, and thanks so much for being here. Hello.
And thank you for that introduction, and apologies. There was a bit of a delay, so I am here and I'm very excited. It's an absolute pleasure to be here with you today, our presenters and all of those in the audience. I really look forward to hearing from the experts, sharing both their personal stories and their expertise, and also those working in the system. I really think that this will stimulate some meaningful dialogue over today, but also the next few days as well.
Great, Nicholas. Thanks so much. Why don't you start by telling us about your work?
Happy to. So, as you mentioned, I am the Director of Access to Quality Mental Health Services at the Mental Health Commission of Canada. I've had the absolute pleasure of being with the organization for 9.5 years. My current role is Director of Access, and what that means is that there are four specific pillars that my team works on. The first being e-mental health. You've probably heard lots about virtual healthcare. E-mental health is just the term that we use, but really looking at how technology has the ability to both transform systems and the delivery of care. The second pillar is increasing access to equitable psychotherapies. The third pillar that the team works on is tools for healthcare providers, not only for the healthcare providers themselves. So we're very cognizant of the mental health challenges that healthcare providers have. So we've built upon the standard for psychological health and safety in the workplace, added two additional psychosocial factors, those being support for self-care and protection from moral distress. So looking at ways to ensure that our providers are doing as well as they can and providing supports to them, but also providing providers with supports to ensure that they're providing stigma-free and recovery-oriented care. And then the last area that the team focuses on is structural stigma. So for those who know the Mental Health Commission of Canada, we've done an abundance of work in stigma reduction, but most of that work is around interpersonal stigma, so the stigma that is between individuals or also even self-stigma. But structural stigma really looks to unearth the stigma that impedes mental health from being on the same plane as physical health. So that could be funding decisions, policy decisions, programmatic, etc. So those are the four areas, and the vision for the team that I work on is to ensure that everyone living in Canada has access to mental health services and supports when, where, and how they choose, that are recovery-oriented, stigma-free, and are culturally appropriate and safe.
So, great work. Before we dig into the topic of systemic change, which you're very much focused on, can you first help us set the stage by explaining what the mental health care system encompasses and why you think it needs to be transformed?
Yeah, it's an excellent question, and highlighting what you did, the experiences that your family has, we have clearly come a long way. But it is a complex question because when considering the mental health care system and what it encompasses, I think one of the biggest challenges that it really isn't a system at all. It's really a patchwork of different systems, supports, and care. Given that psychological services outside hospital settings aren't covered by provincial and territorial healthcare plans, the entire premise of care is based on intervening during the height of a crisis rather than funding mental health prevention and promotion. We also
Mhm.
have multiple levels of accountability when it comes to delivering care that often leaves individuals and their caregivers searching for answers on when, where, and how they receive care. And when supports are found, the wait times can be astronomical. We've heard, about the frustration of those trying to receive care during or surgeries during COVID times, but this has actually been a reality in mental health for decades. And if we think about the medium as the message, what our mental health care system is implicitly telling us is that mental health care remains lower on the priority list than physical health. If we're looking at the definition of a system, it's really things working together as part of an interconnected network. And even though we may not be there when it comes to mental health until we see the funding need, that really is an example of structural stigma in practice. But of course, the news isn't all bad. As we've seen during COVID, the proliferation of virtual services available to the public that would have taken years otherwise to implement. There's also been a heightened focus on mental health during COVID, also in terms of the collaboration between organizations and governments that have led to the development of new resources innovative programs and services to help address the mental health need of those living in Canada.
Yeah.
An example from our work at the Commission is that we developed a trio of free crisis response training programs designed to help frontline workers deal with the stress of these exceptional circumstances. But there are also countless other examples of those working in the mental health system doing phenomenal work with a fraction of the budget of physical health.
Thank you so much, Nicholas. I'm sure we're going to get into some more of that. Nicholas is going to be joining us after each of the speakers today for the Q&A sessions. And great information for us to have as we move into our first keynote address by award-winning journalist and best-selling author Anna Mehler Paperny. Social learning research shows that combining science with storytelling is the best way to inform and inspire change, as I mentioned earlier, for individuals, families, workplaces, and communities. So I'm exceedingly grateful to Anna for joining us today. In her book entitled Hello, I Want to Die, Please Fix Me, Anna chronicles her heart-wrenching experiences with major depression, a disease that accounts for more disability than any other in the world. Her dogged vulnerability was so real and raw that at times I had to put the book down to check in with my own uncomfortable thoughts and feelings. And the science side of Anna's change equation was equally strong. She used her journalistic skills and instincts brilliantly to describe a mental health care system in drastic need of sweeping change. This balanced narrative, and one that I encourage you to explore in her book, makes Anna the perfect guest to kick off this session about systemic transformation. So, without further ado, I'd like to welcome Anna Mehler Paperny and to thank her for joining us because she truly inspires me.
No, thank you so much for the kind introduction, and thank you for sharing your family's story. I think stories like yours are so important, and they're part of the reason this topic really inspires me. So thank you.
The first time I was 24 years old. I was working as a reporter, filing stories in my dream newspaper, and was outwardly thriving. Inwardly, I was a wreck, a dysfunctional tangle of self-loathing, self-doubt, and despair. I wanted to die, and was so mired in despondency that seemed an entirely logical course of action. If you had told me at the time I had a mental illness, I would have laughed. This wasn't pathological. This was just the way I was. I convinced myself I was useless, hopeless, worthless, that the only way out was death. It wasn't rational, this desperate suicidal conviction, but that's mental illness for you. The twisted pathological logic of disease overtakes everything else your brain's got going for you. I told a friend, who called the cops, who showed up at my door in the middle of the night and drove me to a hospital in the back of a cop car. I told the psychiatrist who saw me that I just wanted to go home, and she released me, with a prescription for sleeping pills I subsequently overdosed on, along with what should have been a lethal amount of antifreeze. Spoiler alert, it wasn't. I woke up in the ICU hours later, strapped to the bed and connected to an IV, and surrounded by my parents, worried sick. When I had stabilized sufficiently to toddle over to the hospital psych ward, that was my entry into the labyrinthine mental health care system. It was just the start. I would fumble through innumerable drugs and talk therapies in my flailing efforts to grapple my way to a state of wellness, or at least survivability. I was lucky. I got a psychiatrist who stuck with me through almost a decade of treatment attempts, suicide attempts, and attempts at recoveries. I had health insurance that covered my lengthening drug bill as we went through a parade of pharmacological treatment modalities. I had family support me, refusing to abandon me when I fell down again and again. This shouldn't be a matter of luck. Whether you get care, whether you get compassion, whether you're handcuffed and manhandled or escorted to the back of a police car, whether you're admitted to a hospital or sent away at the door, whether you get a diagnosis that fits reality, whether you get a doctor, whether you get adequate evidence-based treatment, shouldn't depend on your race or ethnicity, your income, neighborhood, employment, or immigration status. but it does. Even in Canada, where we pride ourselves on our public healthcare system, access to care and the provision of care is stratified based on income, race, and other factors. This is true of all healthcare, but especially true of mental health care, which is so subject to bias and interpretation, minimization, and that awful word, stigma. I hate the word stigma. It's become so superlatively overused, it's lost any power it once possessed. What does it even mean anymore? Well, when it comes to mental illness, I'll tell you what it means. You're crazy, you're unreliable, you're untrustworthy, you're dangerous, you're faking it. Stigma and attendant discrimination are the reasons we minimize the seriousness of mental illness as an illness while maximizing the threat posed by its sufferers. They're the reasons employers freak out when they're told that's why you can't come to work. The reasons many insurers freak out when that's the cause of the expense you need covered. They're the reasons Canadian governments act like funding for mental health is a nice add-on, a magnanimous announcement at a logoed podium, rather than a fundamental part of an ostensibly public healthcare system. Stigma and discrimination are the reasons we continue to fail to provide basic care in an equitable way. These inequities began before my first diagnosis, even before my first crisis ward admission. They began with the pair of police officers knocking on my ground floor apartment door. It was the middle of the night. I was scared. I was abashed. I didn't want them to be there. I didn't want to be. But I was a short white girl, and I was cowed and obedient. They told me I had no choice but to get into the cop car to be taken to hospital, but they didn't grab me. They didn't cuff me. They didn't beat me or tase me or shoot me. Maybe I just happened to have exceptionally empathic officers assigned to my case. Maybe I acted remarkably cooperatively. Or maybe the circumstances of who I was and how I acted made that encounter less traumatizing, less painful, and less lethal. I saw the way these inequities play out in my first psych ward stay in the fluorescent halls of the 7th floor of the urban Toronto hospital, where police were more likely to take people in crisis because of their quick admission times, where people would try and check themselves in because they had nowhere else to go and needed a safe place to spend the night. The hospital some used as their home address on government paperwork because they didn't have anything else to put. People would come into the psych ward in a state of crisis, their world collapsing, maybe off their meds, maybe never having been medicated or diagnosed before. Nurses would stabilize them. They'd get some FaceTime with a psychiatrist. If they were lucky, they'd be treated with compassion, like human beings with agency, in a way that didn't cause or exacerbate trauma. They'd get to choose their course of treatment, or at least decide whether to take the medications being prescribed to them, unless the clinical decision had been made to take away that right too. But even if someone is in hospital against their will, even if they're deemed to have lost the bearing on reality required to make their own treatment decisions, and it's crucial that the bar for this designation remains very high, it's possible and mandatory to treat them with respect, like people. This is vital for the emotional safety and psychological well-being of the person in that moment, but it's just as crucial for their future. Callous, abrasive, thoughtless treatment, even if well-meaning, can scar them for years to come, can turn them off treatment entirely. But let's say you luck out and get compassionate, trauma-informed, evidence-based inpatient care. All too often, after spending days or weeks moping around the psych ward, you're discharged into fresh air and nothing. No follow-up visit, no outpatient health provider, no way to get whatever meds you've been given as an inpatient. Certainly no plan of care. This was almost me. I would have been ushered out the door with a pat on the head and a list of phone numbers had my parents not begged for a second opinion, which I got from a smart psychiatrist who saw through my "everything's fine" ploy to get out of the psych ward, who decided I had severe mental illness and needed more time in hospital. I just about lost it. I'm still pissed off about that. But whether or not I needed to spend more time institutionalized, I was unspeakably fortunate to have him take me on as a patient so I could continue to see him after I was discharged. That shouldn't be as rare as it is. Have you ever seen a falling star careening through the night sky and made a wish? That's what it feels like to take psychotropic medication. I began my pharmacological parade while still in hospital in 2011, and it's been going ever since. We tried selective serotonin reuptake inhibitors. We tried selective norepinephrine reuptake inhibitors. We tried dopamine reuptake inhibitors. We tried mood stabilizers. We tried antipsychotics. We tried monoamine oxidase inhibitors. With each switch, with each medication attempt, it felt like we were uttering prayers to magical amulets, but with less magic. Nothing seemed to work if the goal is a lessening of despondence and suicidal symptoms. Although, as I'm often reminded, it's possible these meds were stopping things from getting much worse. But the crucial thing here is that I was getting medications, and I was getting them paid for through my employer's insurance for almost all this time. That's huge. So, too, was my access to psychotherapy in the form of cognitive behavioral therapy through my psychiatrist. I needed that. And if he, a publicly covered health provider, hadn't provided it, I'd have had to seek it out from a private practitioner. These two facts are bananas. How is it that in a country that boasts of its universal health care, medically necessary treatments that are the primary modes of treatment for mental illnesses are not covered? Either we believe in caring for the brain or we don't. Either mental health is health or it isn't. At every step of the mental health system, I was so lucky. And still, my illness did not abate. I know the feeling of the endless, excruciating, aching desire to die. I know the conviction you're a painful burden to those you love the most. I know what it's like to spend nights racked and days paralyzed by ruminations, by the thought your life is not worth living, that you, as an organism, are not worth living. I tried to kill myself numerous times, each time only to discover my organs were more resilient than my sense of self. I tried lithium, I tried paint thinner, I tried parnate. Each failed attempt presented another chance to right my listing ship, to pull myself together, and each time my treatments failed me. What I hope will be my second to last attempt came closest to lethality. I swallowed multiple liters of windshield wiper fluid, was found curled up on the floor of my apartment hours later. It didn't look good. I spent days in the emergency department, organs failing, while someone manually pumped oxygen into my body. Even once I regained consciousness, I spent weeks in the ICU, weeks more in a rehabilitation facility, relearning how to walk, read, write. You'd think, after such a close call and miraculous recovery, I'd emerge with a renewed appreciation for life, a rejuvenated desire to live. But depression doesn't work that way. In the summer of 2019, I checked myself into the Psych Emerge, the first time in nearly a decade of treatment that I had voluntarily admitted myself to a psych ward to get electroconvulsive therapy. I checked myself into hospital because there was no institution that offered readily available outpatient ECT in the biggest city in the country. For weeks as an inpatient, I got unilateral ECT. Then, months later, as an outpatient, I got bilateral. And, astonishingly, the bilateral ECT worked. For weeks, my condition, my mood, my outlook on life, and my self-view improved in ways they haven't since I started treatment. But then the magic wore off. The awful crept back. After 39 sessions of ECT, on and off at varying frequencies over the course of 6 months, we halted that treatment as the despair set in and suicidal ideation returned in full force. The ECT clobbered my memory, and it just about broke me. Not only was I fuzzy during the months I was getting therapeutic electrically induced seizures, not only is that whole period now lost to me, I lost memories going back years. Stories chased, books read, milestones celebrated, health crises wrestled with. I forgot the backstories behind current events, which is especially irksome when you're in the habit of debating your family members at dinner. These losses are painful, gaping wounds I rediscover on a daily basis, my mourning and enraged howl. And yet, I think getting ECT was the right clinical decision at the time, based on the best evidence we had before us. And it almost worked. It didn't, ultimately, for me, and that drives me nuts. But hey, the brain is a jerk, and our available treatments are, frankly, pathetic. Even this drastic, scary treatment is inequitably distributed. A study by researchers at the Centre for Addiction and Mental Health found that people in Ontario who got ECT when they were hospitalized for depression were more likely to be married, well-educated, and live in high-income neighborhoods. This mirrors studies in Europe and the United States. What is going on? It could be that more marginalized people are ending up in hospitals that are less capable of offering ECT, which still requires a significant infrastructure in terms of equipment and personnel. It could be that people with more education are less susceptible to myths and stigma surrounding electroconvulsive therapy. It could be that people without spouses are less likely to have people to support them when they come out from a brain zapping treatment, to pick them up from hospital and take them home, to look out for them. It could be that people with privilege are more likely to trust health professionals, or are more likely to have confidence in their place within the health system, feel more able to advocate for themselves within it. It could be that health practitioners stigmatize already marginalized patients, maybe don't take the time to explain complex treatments to them, or don't ensure they get all the information or options they need. Whatever the reason or combination of reasons, this is yet another example of systemic inequity baked into an ostensibly universal healthcare system. And whatever you think of ECT, and I've talked to a lot of people with a very dim view of it, it means more people with severe illness aren't getting what could be the most efficacious treatment for that illness. I tried to kill myself again in July. It feels sickeningly iterative at this point, to wake up in hospital, to be confronted by your own failed attempts at self-obliteration. The first few times, you get cards, you get visits from friends, you tell yourself you can move on and recover from this. But eventually it becomes, are you serious? Are you kidding? Worried, tired parents by your bedside, angsty siblings on the phone as you look out the hospital window and wonder how best to make your escape. I don't know how to make this go away. There are new treatments I'll try, new modalities my care providers and I will experiment with. I'll go on the wait list for an experimental treatment in a randomized study and hope for the best. But if I'm honest with myself, I really don't know how this story turns out. What I do know, though, is that it's impossible to go through the psychiatric system and not be struck by the need for systemic change. Never has this been more clear than in the midst of a pandemic that has hit the already marginalized hardest, that in many cases has worsened the social isolation that exacerbates mental health crises, worsened the anxieties around wellness and basic everyday interactions, caused already inadequate support systems to retrench, cut their hours and services offered, switch to telehealth, which, don't get me wrong, is much better than nothing, but is no match for seeing someone in person, and which, in addition, is out of reach for people who lack the technology to connect. COVID has shown us how much we rely on one another, but also how fragile our interpersonal connections can be, how easily the most vulnerable can lose vital support systems, and how difficult that connective tissue can be to rebuild once it's frayed. Anyone who spent excessive amounts of time quarantined at home, doom scrolling their way through quasi-lockdowns, could be certain this pandemic will result in a wave of mental illness. And worrisomely, a study has found a fifth of COVID patients are diagnosed with a mental illness within 3 months of contracting the virus. At the same time, people with a pre-existing mental illness are 65% more likely to be diagnosed with COVID-19. But the truth is, we've been facing a mental illness crisis long before the novel coronavirus made its devastating way around the earth. We've long been underfunding and neglecting vitally necessary resources, then acting surprised when 12-year-old girls on reserve take their own lives, when family doctors or caseworkers struggle to piece together anything resembling adequate care for people who need it badly. Change is necessary, and it's possible. We can expand evidence-based preventive services, ensure they're reaching the people who need care most, and ensure they're reaching populations that have been ignored or underserved in the past. The very old or very young, sexual and gender and ethnic and linguistic minorities, BIPOC populations that have been systemically shut out or made to feel unwelcome. We can ensure medically necessary treatments, such as pharmacological intervention and psychotherapy, is covered under the public system. I still can't believe I need to say that. We can expand capacity in our crisis services, both hospitals and alternatives, so that nobody who needs care is turned away. And we can make these facilities welcoming and attractive so that people will actually seek them out and want to go. We can prioritize voluntary care so that involuntary hospitalization and treatment is restricted only to those in dire need of care and for whom voluntary treatment is not an option. This might sound like a minor quibble to anyone who has been placed on a psychiatric hold, told they're too crazy to make their own decisions, but it makes a world of difference. We can ensure all care, regardless of volition, is compassionate and respects patients' rights. We can dramatically increase investment in mental health research to enable ambitious advancements in our knowledge about and understanding of the brain and mental illness, and to improve our ability to treat disorders of the brain. As someone who's been through dozens of effectively ineffectual treatments in nearly a decade of care, I cannot emphasize enough how necessary it is for us to up our game on the research front. But don't take my word for it. Think of Mallory, who went through electroconvulsive therapy and lost her memory but not her depression, who can't remember what she's like without meds, but is still searching for something that works. Think of Jonas, who had an RCMP officer interrupt his suicide attempt, yelling and banging on his window, axe in hand. Think of Deanna, who after years of failed attempts found an off switch for depression and deep brain stimulation, a treatment that remains experimental as researchers struggle to figure out what makes it work or not work. Think of Jarrett, who pays hundreds of dollars out of pocket for an experimental treatment because nothing else alleviates his misery. Think of Jolynn and Brianna, young Indigenous girls on either side of the border, whose communities desperately need not just crisis care, but preventive care. Think of the people you know in your own lives who are struggling. And I guarantee there are people in your life who are struggling. These illnesses cause more suffering, more years lived with disability than any other. We can do better because we have to.
What a powerful
Yeah.
presentation from Anna. So thankful that, and I'm sure the attendees can attest to, the fact of just sharing such raw emotion in her experience. So really thank her for being able to do that and sharing her vulnerability, as you had said, Joe, with her. Of course, I had a question to kick us off before turning it over to our, to our attendees, but maybe I can pause and see if she can come back online. But just, many things within her presentation that really resonated. First of all, really interesting, and we'll bring this back up when she comes back online, around her feelings around the term stigma, which is in discrimination, which is really interesting, as her mentioning how this is really a term that she feels is impeding mental health from being looked at in the same view as physical. So a very interesting perception. It looks like Anna's coming back, which is wonderful. So Anna, thank you so much for sharing your story and for sharing your vulnerability with us. Such an important message. There's a couple of reflections that I had before turning it over to our Q&A, and one of them was just your thoughts and experiences with the word stigma was really interesting for me, and it was something that maybe it wasn't the first time I've heard it, but really really stuck with me in terms of you highlighting that stigma and discriminations are terms that actually impeded your mental health journey and maybe mental health journey of others. So would you mind expanding on that a little bit and just talking about, if we're not using the words stigma and discrimination, what would be those phrases or words that you think would be better suited towards, the experiences you have had and many others?
Yeah, it's hard because, as you say, those concepts are very much active. So stigma absolutely exists and is actively impeding equality and treatment and wellness. But I think it's become so overused that it sort of loses its power. So when you use it, people kind of tune out, or they sort of assume they know what you're talking about. So they'll just sort of take for granted whatever you end up saying. So what I try to do is just really articulate what is at play. So for example, I'll say, like, I think discrimination is a little bit more powerful, but we don't use it quite as often when it comes to mental illness. But I'll say, like, wow, we really are we're acting like mental illness is not an illness when we don't cover the basic treatments in a public healthcare system, you know? Or, wow, my employer's insurer doesn't seem to believe mental illness is an illness because they won't cover my treatments. They don't consider this legitimate. Or like, oh man, you know, my friend has stopped talking to me since I told her that I had schizophrenia or that I had depression. She must have some really like twisted misconceptions around what these are. Or like the police were called to my house the other day and they didn't seem to have any idea how to deal with what I was going through. They must, you know, there must be, like, I might say systemic biases, although that term also has been used a lot. But just trying to be as concrete and specific as possible with the sort of the situations we're dealing with as a way to try to make it impossible for people to tune out.
Yeah.
So I mentioned in the introduction, Anna, about how you were so beautifully vulnerable in your book, which for me made it just such an incredible read. Was that difficult for you? Or if it was, why did you think it was something that you had to be?
It was really hard because, believe it or not, I'm actually a very private person. So this was a huge shift for me, and it really took this really major mind shift very early on to sort of go from thinking like, I'm not going to talk about myself, especially about this aspect of myself at all, to anybody, to thinking maybe I can talk about this with my doctor, and then maybe I can talk about this, you know, with my friends or with my family, and then maybe I can talk about this with everybody. I kind of blame my grandmother, who's a writer and who sort of brought me up to believe I could write about things, because every time since my first suicide attempt, she's been saying like, Anna, you need to write this down. And at first I was like, yeah, Gram, okay, thanks a lot. But after a while I started to try, and I realized I had so much to say. And I sort of experimented and just like wrote a little bit at a time. But the more I wrote, the more I realized I had to write. And so I really had to work up the courage to have strangers read this. And sometimes it's still a little weird, but I'm trying to get better at it.
We have a question from one of our participants, and this could be for either one of you. I realize that you're not mental health professionals, but the question is, are mental conditions the result of some sort of birth defect or caused by trauma after birth? Nicholas, can you take a stab at that?
So full disclosure, I'm not a mental health professional, but I think, you know, from the experience that I have had working in the mental health system, is that the answer is likely both. I mean, there's mental illness that is a result of hereditary issues, but also from, you know, adverse childhood experiences and trauma. So I think it is absolutely from multiple ends of the spectrum, and I think, you know, looking at the possible solutions, it has to look at what the root causes of mental illness or mental health problems at the time are.
Well, thank you so much, Anna. We have to move along to our next presenters, but your insights set us up beautifully for our next session, which is called Upstream Mental Health, the Wave of the Future, with two visionaries who are leading positive change on many fronts. Our first guest, Dr. Trevor Hancock, has decades of experience as a physician, public health professional, and social policy scholar. His passion for a sustainable upstream mental health care system and robust and resilient communities is reflected in the many nonprofit organizations he has either founded or co-founded. More recently, he's putting his wealth of wisdom to work through his writing and editing and being a regular columnist for the Victoria Times Colonist. Also with us is Tyler Norris, who's CEO of the Wellbeing Trust, an American foundation dedicated to the vision of a nation where everyone enjoys mental, social, and spiritual health. Over 30 years, Tyler has shaped health and developmental initiatives in hundreds of U.S. communities and around the world. His extensive work as a social entrepreneur and trusted advisor to philanthropies, health systems, governments, and collaborative partnerships has improved the health of both people and places. So hello, Trevor and Tyler, who will join us after Trevor's presentation. Thank you both so much for being here. And just an aside, if you're interested in upstream mental health, you really must check out our podcast, our first podcast, which featured Dr. Trevor Hancock in a whole episode about that very important topic. So welcome, Trevor.
Thank you very much. It's a pleasure to be here. So, good afternoon, everybody. I am speaking from the ancestral lands of the Lekwungen-speaking people here in Victoria, BC. And thank you for that introduction, Anna, which is, if you like, about the downstream management system for mental health and those with mental health problems. And it's a very important part of the system. But our focus is now to go upstream. So we're going to be talking about this upstream approach. I'm not going to spend a lot of time talking about what is happening to mental well-being because Joanne introduced that very well at the outset. I'm going to touch on the upstream story and what is driving this situation and what we can do about it. I want to begin by reminding us all that actually mental and social well-being is 2/3 of the definition of health. So mostly in terms of WHO's 1948 definition, this isn't just about physical health, but it is, as has already been said, where most of the effort and most of the funding has gone. And that is a huge mistake in the system. So we really need to be focusing on mental and social well-being. Now, in terms of what is happening, I'm not going to repeat all that Joanne said and that I think all of you know, but we do know that mental health problems are a rising burden globally. They're a rising burden in Canada. There's a quote here with regard to Ontario, that the disease burden of mental illness and addiction is 1.5 times higher than all cancers putting together. But the funding, of course, doesn't usually reflect that. The same is true here in BC. So if you look at the Provincial Health Officer's report from 2019, Goal 3 of BC's Guiding Framework for Public Health is about positive mental health. Note that this is framed because I come from public health. I'm a public health physician. Note this is framed as positive mental health and prevention of harms. And Goal 3 is about that. But if you look in the report, almost the only place in terms of all of the indicators of health where things are getting worse is in mental health. And 4 of the 5 measures for mental health are actually moving away from provincial targets. Those reporting mental health, those reporting hazardous drinking, and the proportion of vulnerable children in kindergarten, which is important for something I'm going to be saying later. Now, what is driving this? Well, we know that one of the factors that is driving this is poverty and inequalities. And this is some data, and unfortunately the little red circle has jumped up. It should be circling Canada, which is just below it. But this is a plot from Wilkinson and Pickett's book, The Spirit Level, of income inequality and the percent of those with any mental illness. And as you can see here, the USA, top right, is both the highest level of inequality and the highest level of those reporting mental illness. And towards the bottom there, you can see those countries that have lower levels of inequality or even moderate levels of inequality tend to have lower levels of mental illness. So poverty is a factor. It leads to poor cognitive performance, and in adolescence it increases risks of depression and substance use and so on. And we know that in Canada, Canadians in the lowest income group are 3 to 4 times more likely than those in the highest income group to report poor to fair mental health. And of course, that is much worse for Indigenous people. So Aboriginal youth are 5 to 6 times more likely to die by suicide than non-Aboriginal youth, and suicide rates for Inuit are among the highest in the world, 11 times the national average. This is somewhat older data, but the point is an important one, and I'll come back a little bit to touch on this, but I won't spend a lot of time on Indigenous people's mental well-being because we have someone speaking to that shortly coming up, Margo Greenwood. So this is the Upstream story. This is from the National Collaborating Centre for Determinants of Health, and it makes the point that we are often down here at the bottom of a downstream managing TB, for example, or smoking bans, or dealing with people with mental health problems. But we're not looking upstream where we need to be looking at, as one phrase has it, who is it who's pushing in, or what is it that's pushing people in the river in the first place that are then floating down to us where we gather them up downstream. Everyone is so busy rescuing people from the river that nobody has time to go upstream and see who's pushing them in. But, and this again from the Provincial Health Officer's report here in BC last year, working upstream, that is to say reducing inequities, improving the social determinants of health, will help to address the causes of the causes and mitigate some of the challenges faced by British Columbians. And this is as true for mental health and well-being as it is for all other forms of health problems and health issues. So what is driving this situation? Well, I've already touched on the role of poverty in all of this. The Ontario Burden of Mental Illness and Addictions report makes the point that interventions targeting the determinants of health may impact both mental health and general health in the community, as the PHO had said here in Ontario. And we also, when it comes to Indigenous people, and again, I won't dwell on this, research indicates that colonialism and its associated processes are important determinants of Indigenous people's health internationally. So we have a factor there of great importance in colonial policy, child welfare systems, residential schools, historical and intergenerational trauma that have been very important factors for Indigenous people. Then there are traumatic events that occur even further upstream in terms of time. The notion of adverse childhood experiences, or ACEs, and these are traumatic events such as abuse, neglect, and household dysfunction occurring before the age of 18, and they predict an increased risk of physical, behavioral, and social problems in adulthood, says the Canadian Institute for Child Health. And then we have an emerging concern that I think we haven't yet paid enough attention to as an upstream factor, and that is the growing sense of eco-anxiety or eco-grief or climate grief that is challenging people's sense of security and well-being. There's a concept that developed in Australia called solastalgia, the sort of sense of pain that comes from losing the environment in which you've grown up because of environmental change that is actually human-induced. And that evokes anxiety and grief. Ashley Kunselo is a researcher at the Labrador Institute, and in particular is working with Indigenous communities on how this affects them. And as this powerful sign says from the climate strike protest here in Victoria last year, as the sea level rises, so does my anxiety. And that applies not just to sea level, but a whole host of other problems that are happening out there. So then, what can we do about it? Well, just as with COVID, this can't be managed by downstream care. And so what we're dealing with is COVID. Why are we doing all of these public health interventions? Why should you wear your mask and stay 6 feet apart and keep within your bubble? That's so that we don't exceed the capacity of the system to care for sick people. And just as that is the case for COVID, so it is for this. We need an upstream public health approach to reduce the burden of disease, whether it's mental health problems or cancer or heart disease or whatever. It is far, far better to prevent as much as we can, and not all of this is preventable any more than it is with physical health problems, but some of it is. And to the extent that we can reduce the burden of disease through an upstream approach, then we should, not only because it reduces the cost of the healthcare system, but even more importantly, because it improves the quality of life and well-being for the population. So that's what working upstream is all about. But we're going to be talking somewhat about systems, and I've always been guided by this quote from the Health Institute for Healthcare Improvement. Every system is perfectly designed to get the results it gets. Keep that in mind. It's a really important principle. So it seems to me that we have a societal system at the local, national, and global levels that is perfectly designed to give us high and increasing levels of mental health problems and misery. So we need to look at what we do about that system and what sort of societal system would give us mentally healthy people. And that is the challenge of thinking about mental health in an upstream way. So some of the upstream causes, I've touched on pretty much all of them here: the pernicious effects of inequality, the problems of social disconnection, the undermining of community. Again, you can see it with COVID, the difference in the way that the US and Canada have handled COVID. While we're not perfect and while it's beginning to break down a little, what has really worked better here is that sense of togetherness, of community, of doing it for others, of a collective responsibility. Our loss of connection to nature, our loss of respect for the earth also undermines our mental well-being. A dysfunctional and unhealthy economy. How many people work in what the Brits call shit jobs? Insecure, low wage, little or no benefits. That all contributes to poor mental health, as Tyler will talk about in his presentation. And then harmful cultural values and social norms, some of which Anna and others have touched on already. And then, of course, there are the way upstream issues for Indigenous people that we've talked about as well. And as the Mental Health Commission of Canada noted, the mental health strategy for Canada highlights that a broad range of legislation and policies that were aimed at assimilation have contributed to high rates of mental health problems, addictions, and suicide among Indigenous people. So that too, we need to be conscious of and we need to change. And then we need to look at those factors way upstream in the first 3 years of life. This is the Infant Mental Health Promotion Program at the Hospital for Sick Children in Toronto. So this is what we need to be concerned with. And here in BC, for example, half of those who are vulnerable with one or more early development index indicator were in the lowest income groups, but only 27% in the highest income groups. So again, equity issues and child vulnerability contribute to each other. This is an American model on preventing childhood experiences. What I want to stress here is the base of the pyramid and working up for it is all about upstream work, strengthening economic supports for families, promoting social norms that protect against violence and adversity, ensuring a strong start for children, teaching skills, and so on. These are the things that we have to be doing upstream to reduce the burden of disease and early death downstream. So in conclusion, let me just say that we need to recognize that most of the factors that create health don't lie within the health sector. Health is not, the healthcare system is not the most important determinant of or contributor to good health in a population. It's neither the Minister of Health nor the Minister of Mental Health and Addictions who are the principal creators of health or the systems they manage. The Minister of Wellbeing, mental well-being in particular, is really, if you think about it, the Premier and the whole cabinet. So we need a whole of government approach. You could look, for example, at the fact that New Zealand has actually adopted a well-being budget, and one of their 5 priorities is around mental well-being of young people. And we need what is called a whole of society or a whole of community approach. So it's not even all of government. It has to be much more than that. It has to be all of society and a whole of society approach. So creating a mentally healthy society will mean challenging and transforming our society, our economy, our social norms and values, our whole way of life. And so with that, I will stop and turn this over to Tyler, who will take it from here. Thank you.
Hi, Tyler.
Good to see you, Joe. Thanks for welcoming me, and Trevor,
Likewise.
fabulous presentation. Well, I'm honored to be invited to this conversation. I am sitting today on the occupied, undeeded land of the Ohlone people in what is now known as Oakland, California. We're an urban place, a big city with its heart broken open, struggling mightily with COVID and the associated economic and social disruption that has come from it. I want to begin by giving thanks to the very vulnerable presentation that kicked this off, and Trevor for reminding us that I am sitting in a country that is a model for how inequality and inequity and lack of meaningful opportunity, particularly for Black, Brown, Indigenous, and people of color, translates directly to more challenging mental health and addiction outcomes. I'm going to start with thinking about my own children. I have two 20-somethings in my life. My daughter Eliza, who's 27, often asks me, Tyler, Dad, you have spent your life trying to improve the health and quality of life of communities. And according to the United States Institute of Medicine report, after over a century of increased lifespan of 23 years, a child born today is more likely to live a shorter life than their parents. And her question is, what have you been doing? And I think Eliza's question is very relevant to many of us, asking on our watch, what has happened to what Trevor is describing as those upstream conditions that give rise to health and well-being? How have we underinvested in those? Even as in the US in particular, we have overinvested in a delivery system that continues to create subpar outcomes. The question, what is it that we are doing on our watch, is a leadership question that I hope is a theme for the bulk of today. After spending about 30 some years working in over 500 cities around the US and globally, some of those with Dr. Hancock, I've had the opportunity to lead an organization called Wellbeing Trust. We are a new impact philanthropy with a US scope whose mission is to advance the mental, social, and spiritual health of the United States. We set a goal to decrease deaths of despair by 100,000 lives and to increase well-being adjusted life years, or WALLYs, as the term we could talk about, during that period. And I want to discuss over the course of the next few minutes and perhaps the longer dialogue, what does it mean to build a social movement where distributed leadership is capable across the country, not through some campaign or a policy alone, but by increasing the capacity of our communities, our states, and our country to be able to measurably improve outcomes. Now, here in the United States, if you can, I see this slide is unfortunately not animated right now, in the current piece, so it's not showing the progression. But in the United States, over the last decade, deaths from drugs, alcohol, and suicide have doubled for the last 3 decades in a row. And in the decade to come, they are slated to double again. And we asked the question, along with the US Centers for Disease Control and Prevention and Trust for America's Health, what's underneath death by drug, alcohol, and suicide? And we find this underlying language of despair, hopelessness, isolation, a sense of lack of meaningful economic opportunity. As we come to terms with particularly the US's significant struggle to prioritize a COVID response and the way in which that has led to multiple waves of economic setback, we are now, after facing the likelihood of over 150,000 additional deaths every year from these deaths of despair, are looking at another 80 to 90,000 deaths on top of it because of what's occurring mental health deaths, deaths of despair because of their triggering by COVID. A reminder of what Trevor's saying, that it's something other than access to care that is driving these deaths. So as we unpack what is really going on, and I think Trevor did a great job with this, we may want to look at this as a systemic issue of individual factors that I've named before: loneliness, isolation, a lack of belonging, a sense of inability to express one's purpose, lack of access to nature, or awe and wonder that so many of us through the beauty of a sunset or animals or being in nature, as well as systemic elements, which particularly for us in south of your border, a fragmented care delivery system and lack of affordable access, which is still true for tens of millions of Americans, and the underlying social and economic conditions that don't give rise to flourishing in the first place, all are conspiring to result in deaths of despair. So if we understand the nature of the multifaceted causality in the first place, we have to have a multifaceted response, a systemic response. Now, much of what we're doing in the US is focused on changing public policy to increase access to care and to increase the quality of those vital conditions that give rise to flourishing in the first place, so public policy. Secondly, organizational practice changes. And third, increasing the investment or capital to the things that produce health in the first place. That's a vital layer. We know that if we're going to be successful at that, we need to improve relationship and connections between and across sectors: business, government, nonprofit, the faith community, grassroots leadership, etc., and shift power dynamics. These layered crises around COVID of climate and economics and politics and the racial reckoning that the United States in particular has been going through have reminded us of unequal power dynamics. A longtime friend of mine and Trevor's as well, Dr. Judith Kurland, reminded us that healthy communities isn't about programs and projects. It's about power. Who's at the table? How are decisions made? How are resources allocated? But that means we're going to have to think differently in the first place. And I so appreciated Anna, our initial speaker, in reminding us that it's how we're thinking. When we talk about someone, particularly who's struggling with suicidal ideation or suicide attempts or with serious mental illness, these kinds of judgments and ways that we sort of judge people and compartmentalize people around stigma is part of the challenge. If COVID has done anything, it's reminded us that it is not just 1 in 4 or 1 in 5 of us who struggle. It is all of us. That is in no way meaning to dismiss that percentage who struggle with serious mental illness. It's just to remind us that we are all impacted by what is occurring. So as the only national philanthropy focused on reversing deaths of despair, we have 3 foci: get the care right, get it paid for, and create the conditions for well-being in the first place, essentially Trevor's point. Now, in terms of getting the care right, what that means is integrated whole person care, including the assessment and referral to non-medical needs, and no wrong door. So in the US Framework for Excellence in Mental Health and Well-being, in the orange middle, we're reminding ourselves that any place ought to be a door into an integrated delivery system. And by integrated, I mean that our physical health is being addressed concurrent with our mental health. In other words, if someone is trying to work with their diabetes and eat healthier and move more and cut their tobacco, and we're not addressing the underlying depression, people aren't going to make progress on their diabetes because the self-medication through physical inactivity, through substances, through poor nutrition is how they're getting through the day. So integrated care is vital as a standard, including questions about food insecurity, housing insecurity, domestic violence, or whatever else may be ailing someone. Secondly, we have been focused on public policy to get it paid for. Now, thanks to Health Canada and the public will of the Canadian people, you have a very different issue in front of you. But for example, here in California, where I live, we just passed California Senate Bill 855 that increased access to affordable mental health care to 13.5 million Californians. And the WIT legal decision held one of our payers, United Health, accountable for not living up to mental health parity. That means we need to make sure that we have standards of access for all to mental health care that is commensurate to what people have access to physical health care. And it's a big battle we're fighting here in the US. And then, without repeating what Trevor said, even if you get the care right and get it paid for and give people meaningful access to it, the situation essentially you're in Canada, that opportunity is how are we doing what one of my early mentors, James Rouse, said, creating gardens to grow people in. A healthy community is a garden to grow people in, which means that not only do we need to have access to care, we need to have access to nature, to basic needs, to lifelong learning opportunities, to meaningful wealth and opportunity. When, as we do in the United States, we have a Black population whose net worth is functionally zero in the United States. You can't have a thriving metropolis, particularly when over half of the children born in the United States are Black or brown. We have to address equity as a core issue, not only for health and mental health, but for the economic well-being of the country. All of these are precursors of health in the first place. I'm encouraging you to go to thriving.us for some of what we call multi-solver solutions. Earlier this year, in partnership with the Centers for Disease Control and over 100 US communities, rural, urban, more conservative, more liberal, northeast, southwest, we crowdsourced in the matter of a couple months a series of what we call multi-solver solutions that concurrently renew economic life, renew civic life, and renew social, emotional, and spiritual life, or the theme of this conversation. These multi-solvers are such strategies as ensuring that everyone has access to affordable housing with wraparound services, including food access or mental health care associated with that housing setting. Secondly, that when we promote access to healthy, affordable, fresh, regional food, we can create green jobs, reduce food miles, support food prescriptions, lower our carbon footprint, and improve health status, all by multi-solvers like this. Here in the Richmond and Oakland area where I live, we helped build some businesses called My Cultivar that were hiring former incarcerated individuals who were coming out of incarceration with no savings, very challenging prospects, all kinds of stigma around them. Now, green, living wage jobs, and in fact, the next stage of My Cultivar is a co-op that will allow those individuals to own part of the business that is so virtuous. We're focused right now on building out the mental health workforce of the future. Part of our access problem is our fixation on psychiatrists and psychologists, and Lord knows we need them. But when we're not building out access to the licensed marriage and family counselors or other forms of therapists, not to mention community health workers or peers, people with lived experience, we're negating, we're promotoras who are culturally connected and who can talk with people about what they're struggling about. No wonder we have a provider shortage, because we're only looking at a fraction of those who could be part of the solution. The benefit of this is when we task shift jobs from only professionals into the community, people with lived experience and different skill sets, we're not only increasing access to care and peers and people with lived experience, we're actually able to shift living wage jobs into the community at a very time that jobs are so vital. So those kinds of multi-solvers, housing, food, workforce, access to parks and open space and green life have a concurrent benefit to civic life, economic life, and mental emotional well-being. We see those multi-solvers as part of a balanced community portfolio that is addressing those upstream conditions as well as access to care, and that views a reciprocity with environment where nature is not just a place to recreate, but a place that we recognize our mutuality as human beings with each other and with the natural environment. I also encourage you to go to Wellbeing Trust's site, wellbeingtrust.org, because one of the things we've been doing is focusing at what can be done by mayors, by city and county councils, by community collaboratives. We think this is relevant globally, and we've had a lot of folks around the world say, yes, this is just as relevant to us, to get past the national and state work, provincial work, and focus on what works locally. So you can find this at wellbeingtrust.org. Finally, I just want to lift up one more theme for you all to be thinking about how you can measurably improve mental health outcomes. I mentioned that when we were founded, our foundresses from Providence, in fact, many of them from Canada to start with, said, we want you to focus on a social movement. So we reverse engineered US social movements over the last century. Suffrage and voting for women, the civil rights movement, the environment movement, marriage equality, and said, what are those characteristics of social movements that have changed society, that have measurably produced outcomes that benefit society? And these 7 elements that are in the middle there, pathways, communications, policy, is what we identified through these social movements are essential, these 7 elements. So what we and our partners set out to do is to identify where are those social movement qualities or elements intact, and where they are intact, let's lean into them with existing resources. But where they're not, we need to build them. And so, for example, we partnered with Kenneth Cole and the Mental Health Coalition because they were already aligning communications. There was not a 501c4 policy organization advocating for access. So we founded inseparable.us to take the gloves off and lobby for it. We formed Mindful Philanthropy because there was no philanthropy that was raising money like your grand challenges to bring more money into the mental health field and help the new wealth and tech wealth and high net worth individuals get past whatever stigma, and I so agree with Anna on that, to invest in what matters. We built Mindful to do that. And over the last 7 months, we've aligned the leadership of all of the major US mental health organizations and are releasing next week a shared vision, which we're going to be bringing to the Biden transition team, which is giving them not only content on what ought to be done, but constituency to help give that team confidence that they are not alone and we stand behind them. So I am so looking forward to the dialogue that shall ensue. Thank you for letting an American, a U.S. member in your group today, and I have so much to learn from and with you over this time. Joe, back to you.
Thank you so much, Tyler. I wish we could clone you and bring you to Canada. If you were to work with Trevor, I can't imagine all of the things that we would accomplish here. So while we're bringing in Nicholas and Trevor for a bit of a discussion, I have a question for you about you being on the south side of the border, us being on the north side of the border. If you could take something from the Canadian system and adopt it in the United States, what would that be? What do you think really works here?
Joe, I don't know why, but I found that question emotional for me, and I felt my heart open when you asked that question. One of the things I love about the Canadian people is kindness. Not only the surface level kindness, but the depth of kindness that reminds us that we are one human family. I think that the way in which, and of course you struggle with diversity and inclusion like we all do as human beings, and we other each other, of course. But I think something has occurred in the way that Canadians operate, in the way so many of your communities, that whatever may divide us, that which connects us is greater still. I come from a faith tradition where we're taught to love one another as ourselves. not some transactional golden rule thing where if you do the right thing by me, I'm going to do the right thing by you. Fair enough. That's not so bad. But as ourselves, to recognize that our fates are intertwined and your well-being is the same as my well-being. I wear my mask to protect you. You wear your mask to protect me. When you give me access to care, you're better off. And when I bring it to you, I'm better off. That mutuality, that conviviality is what we pray for in the United States and what we need to build civic will. So I would say it's built on the quality of human connection.
Thank you.
You can,
And Trevor,
you can,
having known Tyler and the work he's doing and having observed the American mental health care system, what do you think that we can learn from Tyler and his colleagues in the United States?
well, I think, first of all, you can see why I love working with Tyler and have done for 30 years.
Yes,
Or more.
I see that.
Incidentally, Tyler, you reminded me of, there was an old joke going around when George Bush said he wanted a kinder, gentler nation, and the joke in Canada was he found one. It's called Canada, and now he's dying. So, but what would I bring from the US? I would bring that energy that Tyler just demonstrates and that is in their nonprofit sector. Our nonprofit sector isn't as dynamic, isn't as large, and it's not as large because government is larger. There was, John McKnight used to talk about it being a kind of a win-lose situation between the size of government and the size of the voluntary sector. So they have a very large, dynamic, active voluntary sector because government isn't there. I think we need the best of both worlds. Government is very important. One of the things we've learned from COVID is how important government is. Well-run government in particular. No fingers pointed, Tyler. On the other hand, what Tyler and others, so many others in the US demonstrate is what a well-run, active voluntary sector brings as well. So we need the best of both worlds. And I'd say that's one of the things I would want to bring up. And also the kind of in-your-face advocacy. I mean, one of the downsides of being kind and gentle is you don't say, listen up, you idiot, do this or else. And there's some merit to being able to say and do that.
Yes. Nicholas, I'd love for you to chime in here now. We will get to more of these questions in the panel discussion at the end of this session. Nicholas, what burning question do you have right now?
First, thank you, Tyler and Trevor, for your fantastic presentations. Seeing some consistent themes, I think, across what we heard from Anna, Trevor, and Tyler. You know, one of the things we've heard a couple of times is around the burden of mental health, and I'm talking about Canadian numbers, the 1 in 5 in a lifetime, or 1 in 2 by 40, the $50 billion, et cetera, et cetera. You know, we've heard about, Tyler, you said the overinvestment in delivery systems. You know, I'm wondering for both of you, why do you think, you know, and we've talked about stigma, but what is the hesitation to investing in upstream and investing in prevention and promotion when in reality these will only benefit both the economies of both of our countries, but also the people living within them? What's that hesitation that is causing both governments to investment in you know, upstream prevention, promotion, et cetera, and from your point of views?
Well, I'll jump in. I think the hesitation is that downstream, you don't really have to change anything up there. You just fix stuff down here. And it's a business as usual scenario. We carry on the way we are, and then bad stuff happens and we fix it down here. If you're going to go upstream, you're going to have to ask some very profound questions about the society and the economy operate. We have to question the levels of inequality we have. You're going to have to question the racism and its systemic discrimination and exclusion. You're going to have to question our focus on profit and money and wealth ahead of people and well-being. You're going to have to question why we don't care about nature other than as a source of things we can exploit and make money from. All of those things, it's questioning the fundamentals of who we are as a society and what we do as a society and how our economy operates, and changing it all, not just questioning it, but changing it all. And that's big, scary stuff, and it sounds threatening and it sounds difficult. And why don't we just carry on as we are and we'll fix things downstream?
I love the question, and I'm going to begin with a response of downstream healthcare is profitable.
That too.
That the $3 trillion that the US spends on this is in pharmaceuticals and care delivery and devices and all this, which God knows have saved lives. This is not to indict the healthcare sector. It's just a reminder that downstream care is profitable and that upstream care pulls money out of the delivery system. So it's a very important economic element. And I think Trevor's point's really well taken. It's complex because when you're saying, well, we need to increase access to transportation that allow people to get to work and to school, and we need to create places that are convivial and create a sense of belonging and placemaking. So much of the benefit of that accrues to the commons. It accrues more broadly rather than the pecuniary interest. So it's a little tougher to really go there. I might just kind of slip one other thing in that may be important too, which is that we notice in the US, a lot of the grant making and the hospital community benefit and all this is a nice grant here, a project there, a few $100,000 here, a few million there. It doesn't add up because the commitment to sufficient, what we call dose, but a little wonkier here, sufficient reach, intensity, and duration of investment that's capable of having a population level impact. We're not holding leadership accountable to it. We are doing good things, but we're not accountable for outcomes. I believe that when you hold the health sector accountable for outcomes, you're going to see a movement towards upstream investments as metrics of accountability.
Although I would add to that, it's not holding the health sector accountable, since actually a lot of it isn't within their jurisdiction. It's holding government as a whole and society as a whole accountable. Every system is perfectly designed, and this is a societal problem. So yes, the health sector should be accountable for the stuff that's within its sector, but it's not accountable for taxation policy or environmental policy or a bunch of other things. So it's both. We have to broaden that accountability. The other thing I just quickly add in terms of what we're talking about, just to pick up on something Tyler said around every door, it has to be the right door. In Britain, for example, they now have a National Academy for Social Prescribing, and they are looking, because about a third of what family doctors see is actually largely mental and social well-being problems that are not amenable to medical intervention, and that's the wrong place for them to be. But social prescribing is being set up to link people to the social resources in the community that can help them make those connections and all of that. And the other thing I just want to stress is Tyler's organization talks about mental, social, and spiritual well-being, and we shouldn't forget that. We tend to forget that, but that's a very important part of it. The relationship with each other, the relationship with nature, it has a spiritual quality to it as well. And that's, I think, a very important piece.
As I mentioned earlier, you can't have a discussion about mental health and systemic change without exploring the Indigenous perspective. Our next guest will do just that. Margo Greenwood, PhD, is academic leader of the National Collaborating Center for Aboriginal Health and is an Indigenous scholar of Cree ancestry with years of experience focused on the health and well-being of Indigenous children, families, and communities. She also holds a professor appointment in both the First Nations Studies and Education programs at the University of Northern British Columbia. And in addition to her robust cross-discipline work, Margo has also worked with UNICEF, the United Nations, and the Canadian Reference Group to the World Health Organization's Commission on Social Determinants. So please welcome Margo Greenwood.
Margo Greenwood Nitsigitsin. I'm Mayhew from Treaty 6 in what is now known as Central Alberta. That's my home and that's my land. I want to begin by acknowledging the ancestors and traditional territories of the Silks peoples upon whose lands I reside and currently work in this extraordinary time that we find ourselves living in. So miigwech to all of them for allowing me to be here in their territory. I want to speak about a couple of things this afternoon in about 8 slides. I'm going to talk about some historical context in which we all find ourselves today. And I think I offer this because there's many of the contemporary challenges that we're facing are anchored in these historical realities. I'm going to be talking about colonization and some of its impacts, and then I'll also talk about attributes of successful health promotion initiatives. So I just want to let you know that, because I know that sometimes these topics can be triggering to people, so please do take care of yourselves. Step away if you find yourself being impacted. And I certainly will not, no judgment here on this part. So what you have in front of you is a slide that really talks about sort of the impact of colonization and colonialism. And I don't think that we can talk about Indigenous peoples without contextualizing our current day realities. I remember, actually, I've been taught by more than one elder who used to say to me, Margo, you can't know where you're going unless you know where you came from. And I you know, there's so many times that little phrase comes back to my mind in all of the work that I do in the university and in my health authority. So I think that's a really important one for us, and I think it happens on multiple levels. When I think about colonization and colonialism too, I think about those as large structural determinants. They're kind of like the superstructures and determinants that impact our lives. And the results of those has had some huge structural impacts as well. And probably the one everybody's most familiar with or is most current is this whole of the racism that's happening in the healthcare system. But I dare to say that it happens across all systems. So I'm going to talk a bit more about these a little bit later on. I think it's really important to remember that residential schools officially began in 1883, but honestly, I've read documents where residential schools can be traced back right up to, back to the 1830s. The first one in Canada was started by the Anglican Church in Brantford, Ontario in 1883. The last one closed in 1996. So I sometimes we think these things are very far away from us, and they're not. They're actually very close to us. Many people that I talk to, parents or they themselves went to residential schools. So it's a history that's close to us and continues to play out in our lives. And honestly, we see that a lot of times in we see it play out. Some good examples of that is Jordan's principle. I don't think I have to tell everybody about that. Inequitable funding of education programs, all sorts of things that are happening are anchored in this reality. The next slide takes a little bit closer look at impacts but looks at those as impacts that we see today. And that we often talk about and we think about. And I think the first one there is intergenerational effects of trauma. I think children didn't experience a lot of warmth and a lot of, rather experience many forms of abuses. And certainly if we are really looking for that, we can look to the Healing Foundation reports and many other documents for information. Certainly the disruption of family and community structures, the cultural traditions and values that are not weren't always learned and couldn't be passed on. So had a huge impact on the loss of parenting knowledge and skills as children were taken away as young as 4 and sometimes never return until 16 years old. So huge impact on the social fabric in our country. So I'm not going to read each of these. I think probably a lot of you know this context already. But I think it's really important to understand that this is the reality for many Indigenous peoples across this country. And it is their history and contemporary situations in which they find themselves. The following slide really looks at the determinants of health. And one of the bullet points on the previous one was to make the point that many of our people are experience lower levels of education, employment, income, and a lot of this results in food insecurity and so on. Lack of access. But I think this is really important slide because we can talk about those things, and certainly all of those determinants intersect with one another, and so we have multiple inequities bearing down on individuals and families. But I think what's interesting about this, there's many lists of determinants of health, if you will. But here's some that over the years, our work at the Collaborating Center and writing and thinking about this are some of the specific Indigenous specific determinants that bear down on First Nations, Inuit, and Métis people's lives. So there you have it, colonization, you saw some of these on the previous slide, residential schools, colonialism, multiple forms of discrimination. Racism, including microaggressions. I always find those so fascinating. I can recall when someone came up to me and said, well, you don't look like an Indian, Margo, you know? And it's the subtlety of that in so many ways that happens for people. Self-determination, language and culture, indigeneity, who we are as Indigenous peoples, our geographies and our locations, and absolutely our spirituality, our connections to the land. So when we're thinking about determinants of health, and I'm glad to see that they're using determinants of health, we made the case in this that determinants are beyond social, that we think about some of those unique realities that happen for First Nations, Inuit, and Métis people in this country. The following slide looks at some of and I know that many of you can add to this list, so I tried to get thinking about this and from the literature, things that I could remember that were really, really important. Some of the contemporary challenges and that we're facing right now in the work that we do is culturally safe mental health services. What does that mean? When do we know when it's culturally safe? How do we ensure that for those that we're serving? Long-term funding, oftentimes I don't know how many stories I've heard about, well, we have a project, but it's going to end on such and thus. And so that's not helpful for us. Access to services in some of our rural and remote and isolated communities, there aren't even services. And so where do you have to go? What if you can't travel to get there? And I know that there are some really innovative projects in British Columbia right now around this. through the Joint Project Board and the mobile support teams and other projects that we see in the province trying to address and ensure people have services closer to home. Trained Indigenous mental health workers, a real need there for folks for training and to be able to participate in the mental health work. Continuity and specialized services, so continuity of care. And what happens when we need specialized services? Is there access to that or not? Is it prohibitive? Can we access those services when they need them or not? I was just talking with somebody that was doing some work in the school system, and they were talking about, wow, there's a lot of lot of labels and such in the school system. Children getting labeled, but where are the services to go behind it? Where are the supports for that? And I think we see that a lot. It's one thing to identify something, but it's a total other thing to make sure that the supports and services are there for the individual and the family, especially children. I see and hear about that a lot with it for children. And of course, stigma and discrimination. Just the whole stigmatizing of mental wellness and mental health is huge, and we hear lots about that. And so those are challenges that we are facing. I think people are facing all the time. And how can we support them in making sure that they're getting the supports and services that they need? And I'm sure you can add more to this. So believe me, these are not all of them. The following slide talks about protective factors. And really, I was looking through some of the work that we've done at the Collaborating Center and some of the research. You'll find these things in some of the research of Chandler and Neilane, Bosca, Kermeyer, a number of people who are doing research in this particular area. And what are those things that are going to protect us and promote our resiliency and our abilities to cope? And so we have cultural identity and community self-determination. Probably none of these are new to you folks in this room, in this group. Identity and pride and values. Certainly, these were a study done by Curry et al. In Edmonton, found that the degree to which Aboriginal peoples identified as being Aboriginal with a sense of pride and integrated their Aboriginal norms and values into their being was associated with reduced drug use. So I think there is absolutely hope. Integration of Indigenous and non-Indigenous knowledges. So we see this and hear in the world that I live in, certainly, what are the strengths of our communities, our knowledges, and where else can we draw from other strengths, from other knowledge systems. And so this is assuming that there are distinct knowledge systems. My grandfather, my mushum, used to say to me, because I would ask him all sorts of questions all the time, and he would say to me, Margo, you take what's best from all the places, because that's what we need to figure out what we're doing today. So we take the best of everything to use it to address the challenges that we're facing. So his words come to me often in the work that I do. Land-based activities, I don't think I have to go on about that because I think a lot of you know this already. Hunting and spending time on the land can help promote individual factors like self-reliance and self-confidence, and also engage in mentorship opportunities for young people and building kinship when we're on the land with our family, our extended families, our friends. It has so many values, and it doesn't even begin to talk to the spiritual value of being on the land. I once had an elder I still have an elder teacher who often talks about, Margo, all that we need to know is written on the land. So how many times do we have at the end of the day, just let me get outside so I can go for a nice walk? It always feels good to get to the land. It's the one constant, it feels like, in many cases, although it's radically changing. I was just saying to my colleague the other day, the seasons come and they go. They may change a bit in the dates if we're going by the calendar, but they do come and they go. And we are going to go into winter and we'll go into spring. So it gives me peace in these extraordinary times. I guess I'm sharing my own thought there. Sorry, I'm diverting. Positive role models and mentorships are really important, as having those opportunities for individuals. Safe places. Where are the places that are safe that people can go, that they can talk, or they're physically safe? Where are those safe places? And I think the importance of family connectedness and importance of extended family are other protective factors. The following slide shifts our, from protective factors, Scott, to attributes of successful mental health promotion. So some of the work that we've done at the Collaborating Center and some of the other readings that we've done is characteristics of mental health where they've been, mental health promotion where it's been successful, is they've been holistic and community-driven and owned initiatives. They build capacity and leadership in the community so that in all the work that we do, we're sharing that information with community, supporting them to take leadership in that regard and to have the capacity to carry that on. Emphasizing strength and resilience. I cannot underscore this enough. I think it's in every arena I move. We are always trying to bring forward and talk about the strengths and resilience of our communities. Oftentimes we are always hearing, I could have presented a whole pile of stats that would have been just showed us as the poster child of inequity in this country. But rather, I would rather spend my time thinking about the strengths that community has, the resilience that community has to move forward and to address the challenges as they see them. So I think that's a really important place for us to spend our time, is thinking about strengths. I think we have to consider the context too, and this addressing health determinants is really speaking to those underlying contexts like lack of housing, lack of education, lack of food, all those kinds of things. How do we begin to address those so that we can support people that in better ways? Because these are absolutely intersect. Focus on protective factors. So some of the things that I just talked about, and there's many more. I had a list that's probably 50 long, but there's many of those. And how can we focus and put our energies on that? And I think it's absolutely fundamental in this kind of work that we engage children, youth, families, and community. I mean, it is them that we serve. And so how am I engaging them so I understand that I come to understand that particular reality, and what are the things that I then need to do to support them? And I could be a frontline clinician, I could be a policymaker, but nonetheless, all of us have a role in whatever we're doing to support these families, these children, in optimizing their health and well-being. Some examples of health promotion strategies I drew from a document from the National Collaborating Center for Indigenous Health. And you'll see that, Scott, we're on the next slide, please. Thank you. And I'm not going to go over these, but the National Collaborating Center has a number of documents on its website that speaks to mental wellness, health promotion, and some of the very specifics around trauma, stress, depression. There's a number of documents on there. Anyway, I was able to draw from a couple of examples here. So one is around Inuit youth, skills and knowledge to build, they need to build their lives, and that's really based on IQ to become a fully functioning, competent human being. as I understand it. I'm not Inuit, but my Inuit friends explain that to me. Another is just outdoor activities that are aimed at enhancing relationships and all sorts of physical and mental health, employability, and listening to one another. Fact-funded, family-centered program. That's a FACT program. And it really looks at a number of things for young people between 10 and 14 years of age. The following slide also is around mental health promotion strategies, and these are more at a systemic level. And I really, I have 3 documents in here that I came to mind as I was thinking about this work. The First Nations Health Authority's policy on mental wellness and cultural safety. I'm always struck by the 5 principles for transformation, as we all acknowledge that there's a need for change. And here's some principles that can guide our journey in that change. It's focusing on strength, and so that's, we've heard that, and a new way of looking at promoting mental health. Bringing together Western and traditional practices, so taking the best of everything to meet our current challenges. Improve quality of programs and services. So looking at equitable access, culturally safe, trauma-informed, compassionate care. All of those sorts of things really fit in there. The integrated system design and service delivery, honoring cultural teachings around the need for being holistic and balanced. And then First Nations self-determination, including nation-based and nation-building approaches. So this is where communities and families can be directly involved, and decision makers and planning around programs and services designed to support them. We also have the First Nations mental wellness continuum. That was AFN and Health Canada. We have the National Inuit Suicide Prevention Strategy, and they both call for a coordinated continuum of culturally competent and safe mental health support. So a continuum of services. And at the heart of this is culture and the role of Indigenous language, identity, and knowledges. So when we look back at this whole thing, many of these factors of success that we saw in research and we see now in policy papers are reinforcing each other in the items and the topics or attributes that they're bringing forward. What can I do? Here's my last slide. So I always ask myself this question. So what is it that I can do if I'm a health practitioner in my world, and in this case, mental wellness? Educate myself. What don't I know? The more I know, the more I don't know. That's what it feels like. I think that's what happens. So what do I need to learn? Know my own biases and how they affect my work. We all have them, and they all influence us. We don't sort of put those aside when we go into our workplace, but they're part of us. And so really just being able to reflect on our biases and whether or not they're affecting my work in a positive way. Talk to Indigenous people and organizations. Learn about the social and cultural context of Indigenous people. So some of the stuff that I just mentioned, I mean, that's like you could do a degree in some of the things I've just mentioned very briefly. Social and cultural context. Commit to providing culturally safe care, whatever that looks like, and our community will be able to guide you with that. Support Indigenous mental wellness workers. So all of those workers that are out there, how do we support them? Where do they go for the supports? Because this is not easy work, and I don't think I have to say that to any of you. It is not. Advocate for health equity. Understand programs are guided by Indigenous knowledges, and share knowledge on promising practices in Indigenous communities. And that's just to name a few, and I'm sure all of you on this line could probably name a whole bunch more that I've missed. So if you can go to the last slide, I just want to thank you for the opportunity to be here. And again, my apologies for not being very technically savvy. And I did skip pretty fast over this. So, miigwech.
Oh, Margo, I thought that was amazing. Thank you so much. And we're going to have some great questions for you during the panel discussion. We're going to move on now to our next presentation. You might not know, but BC is the only province in Canada to have what it calls the Ministry of Mental Health and Addictions, and among the first to have a comprehensive roadmap for positive change. This is called a pathway to hope, and this good strategy is will be made even better by what we're learning from COVID-19. So we're going to now introduce Deputy Minister of the Ministry of Mental Health and Addictions, Neilane Mayhew. She has almost 20 years of public sector leadership experience in various ministries, including the Ministry of Indigenous Relations and Reconciliation, the Ministry of Provincial Revenue, Ministry of Small Business and Revenue, and Ministry of Finance. So please help me welcome Neilane Mayhew.
So good afternoon, everyone. And I really appreciate the opportunity to join you this afternoon. I want to begin my presentation by acknowledging the territory. So I am coming to you from the unceded territory of the Lekwungen-speaking people, presently known as the Esquimalt and Songhees First Nations. And so I would like to acknowledge their territory. As well, I would like to acknowledge the Métis Chartered community of Greater Victoria, and also all urban Indigenous people who call Victoria home. I'd also like to thank Joanne and Fresh Outlook Foundation for giving me the opportunity to participate in this summit as a speaker. It's been fascinating for me to hear everyone ahead of me. I did in particular, though, just want to acknowledge and honor Anna's story and the courage for her to share it with us, and the lived experience that she's brought to the dialogue today. And I think thematically, we've heard a lot about it will take an all of society working together to improve the mental well-being of British Columbians, Canadians, all of us. And so I think the summit has really offered a really invaluable opportunity for a diverse range of people from different backgrounds, different sectors, different cultures, different organizations to come together and have a conversation around mental health challenges, opportunities, and solutions. So appreciate being here. So I will, recognizing I think we're a little bit behind, I will try and make up a bit of time, but I did want to just give you just a tiny little bit of background around the ministry, talk a little bit about what we heard when we were out talking to people about building a mental health and addiction strategy. I'm going to touch on a pathway to hope, which is the province's mental health and addiction strategy, and a few of the initiatives that we're collaborating on that are part of that strategy, and then pick up just a little bit on some of the lessons that we've learned from our COVID-19 response and where some of the opportunities may lie there. So the ministry was created in July of 2017, and as Joanne mentioned, it was the first ministry of its kind in Canada, and it really offered an opportunity for having a minister and a team which was solely dedicated and focused to both responding to the overdose crisis, but importantly also focusing on what needs to be done to improve and transform the mental health and addiction system. And so in the context of our role, we actually are not responsible as a ministry for direct service delivery. So we aren't actually delivering as the ministry the services and supports that government and many of its community agencies deliver. Rather, we work at sort of a systems level and at a strategic level, which has actually given us a particularly unique, I think, position in that we were not invested in the status quo because we're not actually involved in the direct service delivery. And so we were able to sort of take a step back, look at the system as a whole, and challenge some of the assumptions, challenge some of the issues, and really try and look at things, I think, from a new vantage point and a slightly different perspective. But we also knew we needed to be collaborators because we don't deliver the services and because the system is incredibly complex. We really needed to build strong partnerships and strong collaboration relationships with a range of people. And so ultimately, we are built as a collaborator, and our role is focused on working with community partners across government ministries to break down those silos, to kind of try and reduce some of the fragmentation and reduce barriers in accessing services, and ultimately to set the strategic direction for the mental health and substance use system of care. And primarily, we were tasked with developing, as I said, a strategy that would transform mental health and substance use system of care in British Columbia. As we set out to build the strategy, we knew that we needed to talk to people. We knew it would be critically important. In all my years of working in government, I know that if you go off and create policy in a vacuum or create a strategy in a vacuum without actually talking to people who are experienced in working in the system or in receiving services or programs, you just will build a policy or a strategy that's not going to be particularly effective. So we knew that we needed to go out and talk to people. And so in the spring of 2018, we launched an engagement process that had the minister actually going around the province and hosting a number of roundtables. And those roundtables were really aimed at ensuring we got sort of diverse voices. And so it was important in doing that we hear from people who might not have always had a critical voice or who may be disproportionately impacted by mental health and addiction system. And so we undertook roundtables with children and youth, with families, with people with lived and living experience, members of the LGBTQ2+ community. We also talked to Indigenous people. We worked very closely with the First Nations Health Authority, with Métis Nation BC, and with other Indigenous organizations. We talked to South Asian and Chinese community. We talked to service providers, people who are delivering the services, community agencies, and a number of people in the supportive recovery community. So we did a lot of talking and a lot of listening, more than anything, I would say. And here's some of the things that we heard. We did also, as good strategies generally do, looked at data. We looked at information. Some of the data and information has already been referenced by earlier presenters. Trevor mentioned the 1 in 5. I think some of the disproportionate impact for Indigenous people has also been talked about. And so we did look at a lot of data, a lot of information, a lot of reports. There are copious number of reports that have been issued over the past 10 years around why the mental health and addiction system is not working effectively in meeting the needs of people. And there's copious number of recommendations in those reports as well. So we kind of took all of that information from the roundtables, took a whole bunch of information from research. We talked to a number of experts, and ultimately that informed the building of a Pathway to Hope. And so a Pathway to Hope, what it represents is a 10-year vision with a roadmap that sets out the long-term direction for a new system of care. And it was struck by some of the earlier presentations as well, talking about every door is the right door. And certainly that was a core component of that vision. But it's, as a 10-year vision, it sort of sets the roadmap, but ultimately it's supported by a series of actions. So those things that we would undertake immediately in the next 3 years, and they're organized around 4 focus areas, which I will talk about in a minute. But I wanted to just speak to the fact that it really emphasizes prevention, promotion, and early intervention. So some of what Trevor was talking about in terms of the upstream, although recognizing some of that upstream is still within the health system that we were talking about. But in building the pathway, like, we partner with ministries beyond the Ministry of Health. We partner with Ministry of Municipal Affairs and Housing. We've partnered with the Ministry of Children and Family Development, the Ministry of Education, the Ministry of Social Development and Poverty Reduction. And so there really was a recognition that we needed to place more emphasis on those upstream interventions and trying to address and respond before problems and challenges become more acute. I think the other interesting thing about the pathway is it sets the strategic direction and the long-term vision, but it's also intended to be a bit of a call to action. And so acknowledging that we as government certainly have a large role to play because we are a deliverer of a multitude of services, but at the same time, government alone cannot ultimately transform the system. We need the help of many layers of government, so federal, provincial, and local government, but also community agencies, families, people, businesses, all of society. And so it really was a bit of a call to action for all of us. As I mentioned, there is there's a 3-year action plan in the pathway, and these are the 4 I'll call them pillars that have specific actions and initiatives underneath all of them. But what I wanted to kind of emphasize here is that, like, the core of the vision is around transforming the system, and so each of the initiatives underneath are aimed at trying to actually change the status quo, because we knew that ultimately simply maintaining the status quo but providing more investment into the existing system was not actually going to get us where we needed to get to, and would not be effective in meeting the needs and demands of British Columbians. And so the initiatives were identified and designed to ultimately try and transform the system. But I want to acknowledge that change takes time, change is hard, and I think that this will start us on the path in terms of the things that we have laid out in the 3-year action plan, but that's not going to get us to the longer term vision. And so I think it's important to kind of keep in mind that, again, change is going to be hard, and change will take time. In the next couple of slides, I'm going to highlight some of the things under 2 of the pillars, but I actually wanted to just pause here and talk a little bit about the supporting Indigenous-led solutions. I didn't have that in my slide, but given the conversation earlier, I just wanted to touch on that a little bit. At core to the pillar around supporting Indigenous-led solutions is self-determination. And so the initiatives, some of the initiatives under there are really about supporting nation-based and community-driven solutions, so that we in government are not the ones that are designing or delivering the solutions, but rather we're enabling nations to build capacity and deliver the solutions that make sense for them. And so self-determination is a really core element to that pillar. The other couple of things I wanted to just say around that is what I've learned over my many, many years is that we have much to learn, I think, from Indigenous people and Indigenous culture. And I was struck by some of the comments that people made with respect to, how we can support mental well-being. And one of the first things I learned when we started talking with the First Nations Health Authority is to talk about mental wellness, not mental health or mental illness, but talk about mental wellness. And that emphasis and focus on wellness is really, really critical within First Nations culture and Indigenous cultures. The other part for me is just the holistic approach. So very, very early on in joining the ministry, I went around the province actually and had an opportunity to meet directly with a number of First Nations leaders throughout the province and talk to them about the role of the ministry and what we were trying to do. And it struck me just based on that, mental health and wellness came up as one of the highest priorities for them in their communities, but also what they shared with me made me really reminded and remember that a holistic approach is absolutely critical, and that we do need to look at social determinants of health and social determinants of mental health. Language and culture are social determinants of health for Indigenous people. And so when we embark on anything that we do in terms of strategies, I think we need to remember social determinants of health, and that culture, language, land, all of those things that Margo talked about earlier are social determinants of health for Indigenous people. Before talking about a couple of the other initiatives, I did also want to just touch on, we had some guiding principles that are laid out in the pathway. And lots of these themes I've heard come up in some of the earlier presentations. And we felt it was important to include guiding principles because we knew that, again, in order to try and signal how you're trying to transform or where you're trying to get to, being really clear about the principles and what we're shifting from and what we're trying to shift to was really important. And so lots of the things, as I said, that have been talked about earlier are reflected in the pathway. So this concept of building resilience, but the building resilience really being around a proactive approach focused on early intervention and supporting communities and people in terms of building resilience. I heard, in a number of the presentations, the importance of valuing diversity, and that you can't kind of have uniform programs and services and expect those to meet the needs, and that programs and services really need to meet the unique needs of the people that they're serving and the local communities. And so that, again, the importance of community-driven solutions, collaboration. This summit itself actually is a reflection on collaboration, because we're hearing from such a wide range of people, and certainly innovation as well. And so that idea that we need to be willing to experiment and willing to change some of the ways that we're doing, and that maintaining the status quo is not an option. So just a little bit on the improving wellness for children, youth, and young adults. Certainly in the work that we did, and some of the statistics were referenced, I think, earlier by others, but there are, we know, at least 84,000 children and youth within the province dealing with a mental illness. And we know that probably only a third of those are getting access to any services that might support them. Social emotional development was referenced, I think, earlier by Trevor, and the fact that we're seeing, sort of more kids being vulnerable in terms of social and emotional development as they're entering into the K-12 system. And we also know that demand and need is far outstripping capacity, and we know that typically, most serious mental illnesses are going to show up in adolescence. And so for all of those reasons, we did feel it was critically important that we focus some of our efforts on improving wellness for children, youth, and young adults. And so under that pillar, there are a range of initiatives. They're listed here. You can see some are focused on promotion and prevention, and while others are focused on stronger integration. And I'm just going to talk about two of these. So one being the integrated child and youth teams. So these teams are going to provide wraparound services to children and youth aged 0 to 18 with mental health and substance use challenges. And we are starting in 5 communities. And when I say communities, we are using school districts as a bit of a geographical organizing structure for us in terms of where we are rolling out the teams initially. That doesn't mean that there would necessarily only be one integrated child and youth team per school district. The number of teams there would be within a school district would depend on a multitude of things, the needs within that area, as well as its population, et cetera. And to be clear, because this has come up before, it's not that these teams are located in schools. Again, the school district is a bit of a construct for us in terms of geography, but it also enables us to then establish at a bit more of a local level partnerships with the school district, partnerships with the local health authority, et cetera. And so fundamentally what these teams are going to do is ultimately be connecting with children and youth and providing the right care when and where they need it. And so some of the key elements are, it would be potentially outbound. So these teams will go to where the youth is comfortable or the child and family are comfortable meeting with the team. And so that may be in their home, that may be in the school, but it may be elsewhere in the community. The other kind of key element is that there needs to be a collaborative planning process. And so these will be formal multidisciplinary teams, and they will develop with the child or youth and their family a plan, and not 5 plans where the youth and family are then left to go and navigate the system, but rather a plan in terms of the services and supports that are needed and how those connections are going to get made. The teams will be formed using some existing resources, but also adding in new resources where there are gaps identified. And within the service framework, there are specific practice principles. So that was talked about earlier as well, I think, by Tyler. So trauma-informed, child and youth and family centered, culturally safe. So those are some of the practice principles that are embedded in the service framework. I mentioned that we're starting these in 5 school districts. So the first 2 communities out the gate will be Maple Ridge and Pitt Meadows and Comox Valley. And then 3 more communities were announced just a few months ago in September of 2020, and that's Coast Mountain, so that's up in the northwest. Okanagan, Milkameen, and Richmond are the balance of the three districts. The other initiative I wanted to talk about under the child and youth pillar is Foundry. And so for those that aren't familiar, Foundry Centers provide services and supports to youth aged 12 to 24. The centers offer primary care, mental health and substance use services, peer and family support, other social services, connection to employment resources, for example, and it's all under one roof. So a youth can go into the Foundry Center within their community and access all of those services and supports at one location. The model is basically fundamentally relies on an integration of a whole range of existing services within a community. And so services by multiple agencies would be provided from that one location. And so it's actually a very unique model in that it brings together, as I said, a multitude of community-based agencies or ministry services all under one roof. And I think the last count, there was one of the Foundry Centers had, I think, upwards of 40 partnerships at the table providing services under a single roof. So under the Pathway to Hope strategy, we specifically provided for an investment in more foundries throughout the province. So there are 11 right now within the province, and the Pathway committed to an additional 8 centers throughout the province. Those 8 new centers are going to be in Burns Lake, Comox Valley, Cranbrook, Langley, Squamish, Surrey, Port Hardy, and Williams Lake. If people are interested, the existing 11 are in Abbotsford, Campbell River, Kelowna, Penticton, Prince George, Vancouver, Ridge Meadows, and Victoria. And there's 2 that are almost operational. They're under development right now in Richmond and in Terrace. And so in 2019, for example, there were 10,000 youth across the province who accessed Foundry Centers. And so with the expansion from 11 to 19 overall within the province, we certainly expect Foundry will be able to expand its reach. And then one of the things that we were able to do as part of our COVID response was to provide some investment to Foundry to actually quickly stand up a Foundry virtual clinic. That's actually providing counseling and peer support by phone, text, and chat to any youth anywhere in the province. And so that's actually been, from my perspective, was one of the great opportunities coming out of COVID was our ability to leverage our work with Foundry, and also for them to quickly be able to pivot and roll that out so that it's available to youth across the province. The other pillar I was going to talk about was the improved access and better quality. And so there's these are the key initiatives that are outlined under that pillar. And then in the next 2 slides, I'll just spend a couple of minutes talking about 2 of them. One that I wanted to talk about was expanding access to affordable counseling. So In 2019, we were able to provide $10 million of funding over 3 years to increase access to community counseling services. And how this was done was working in partnership with Community Action Initiative, who basically put out a grant call across the entire province for any community agency who is providing existing community counseling services within the community to expand or enhance their services in order to be able to provide services to people with low income or to other vulnerable populations who may not have ready access to counseling. And maybe just I'll take a quick little sidebar because this was touched on earlier. I mean, we would acknowledge that we do not have a publicly funded mental health and addiction system. I say that frequently, both in government and out of government. So, you know, there are copious amounts of services that are not delivered as part of the publicly funded system. And certainly access to things like CBT and other forms of counseling is one of those things. And so often it relies on your bank book to be able to afford to be able to go to counseling, or you need to be accessing services through your employer if your employer does provide them, and not all employers do. And so what we were trying to do here was expand access to counseling for those who might not otherwise get access. And we did so by trying to leverage existing community agencies rather than rolling out a new, you know, shiny government program. So it's provided funding to existing community agencies, and you just see a snapshot here with respect to kind of where they were located within health regions, so how many within each health region, as well as 2/3 of them are focused on people who face barriers, including financial hardship. 1/3 of the recipients are focusing on supporting Indigenous people, and as well 1/3 are focused on rural and remote communities. Team-based primary care is another initiative that's outlined under the pillar around improving access. And, you know, fundamentally, team-based care is recognized as the best approach for delivering effective primary care. And the Ministry of Health is the lead for delivering on the overall primary care strategy. But we've worked very, very closely with the Ministry of Health to ensure that it's clear that there's both an expectation and a requirement that primary care networks include mental health and substance use care. So, you know, those that are dealing with mild to moderate mental health or substance use challenges need to be able to get those services through those primary care networks. And we've also set what I would say is an expectation with the Ministry of Health in terms of strategic direction, that there needs to be clear and integrated handoffs from primary care into more specialized services if individuals need those more specialized services. And so, you know, how we've done this is essentially set the strategic direction and the expectations for the Ministry of Health to ensure as they roll out in their primary care strategy. Lastly, just talk quickly about the COVID-19 response. And as I said at the front end, I think there are certainly some opportunities here. You know, we know, at least from what information we have so far, that more than half of British Columbians report experiencing worse mental health during the pandemic. We also know that the impact of the pandemic is not felt equally. So Indigenous people report higher levels of somewhat or much worse mental health than non-Indigenous people. The same is true for younger age groups. They report worse mental health than older age groups as well, for recent immigrants and certainly others as well. So we know that there is an inequity in people's experiences, and we also know that there is a disproportionate impact on people's mental health. We're also seeing increased volumes in accessing services like crisis lines and other mental health supports. And so very quickly, we did try to stand up and roll out some enhanced services. And so we used some of our existing partnerships to be able to put in place additional mental health supports. And some of those are listed here. The community counseling initiative that I referenced, we were able to, because there had been such amazing interest an application into that grant process. There was, I guess, what I would characterize as another sort of an eligibility list that we could draw from to provide funding to an additional 20 organizations on top of the 29 that we had previously provided resources to. And so we now have 49 community agencies providing those services and supports. And we were also able to provide funding to enable them to quickly pivot to virtual services. We expanded some of, supported CMHA to expand some of their programs. As I mentioned, the Foundry Virtual Clinic, and so that was launched just a couple of months ago, and it's available to any youth within the province. But what I wanted to just kind of end with is sort of two thoughts. One is we are turning our mind now to ongoing need. So recognizing there are studies out there that tell us that typically you will actually have quite a bit of a longer term impact in terms of people's mental health and mental wellness following a crisis or a pandemic. And so we're recognizing and trying to think through what we need to put in place to help support people moving forward, because at some point the pandemic itself, will quote unquote end, but the impact of that on people's mental health and mental wellness is going to continue for quite some time. And so we're trying to think through what we need to be doing in terms of readying to support people through that, and also wanting to use what we've learned and use the opportunities that have sort of come up and not lose those when we come out of, for want of a better word, the current pandemic. So things like that pivot to virtual services. I know that we've gotten feedback from a number of both community agencies, but also individuals that for some that they weren't able to access services because it was not viable for them to come into a community agency, and yet they are able to access services virtually. And so the reach for some community organizations has been expanded quite considerably by being able to provide services virtually. Now, I do want to acknowledge, though, that it's not all good. For some, accessing service virtually does not work, and certainly people where they don't have privacy within their home, or their home may not be a safe place. So for them, accessing services from home isn't ideal. So I just want to acknowledge that. Having said that, though, I do think that we don't want to lose the good opportunities that come from potentially being able to expand reach through virtual services. Also, we've noticed, at least within the provincial government, but as well in lots of the discussions we've been having, certainly mental health and mental wellness is now much more talked about in the context of the COVID response than I have experienced in the last couple of years as we were building the strategy. So it has come to the forefront, and I do want to acknowledge Anna's comments about stigma, and I wholly agree with that. I do think that the pandemic, though, has given us it's been a bit of a lightning rod for at least enabling some conversations that hadn't been enabled before about the importance of mental health and bringing it out a little bit from the woodwork. So with that, I will end there, recognizing I think I've used up more than my allotted time.
That's wonderful. Thank you so much, Neilane. Great work you're doing. And I just wanted to ask a question. What is being done to support equity disparities among people of different races and different genders, that kind of thing?
Well, I'm not sure if the question's aimed at disparities in terms of access to services in terms of mental health, or if it's inequities from sort of a fiscal perspective, but I'll maybe speak to the former. So one of the things that we, is part of the Pathway to Hope is an acknowledgement, as I said at the front end, in terms of some of the people that we talked to, is there are a number of vulnerable populations whose access to mental health and addiction services, they have more barriers to access, and the services that they access are not safe. So for sure, we talk about Indigenous people in terms of cultural safety and humility, but also acknowledging that there is racism in the system. There are other inequities in the system in terms of other ethnicities and vulnerable groups being able to access services and support. So as a foundational element of the vision as a whole, it does speak to culturally safe, and that's in the broadest sense, services and supports.
So Tanya has another question, and she asks, do you think that political cycles have an impact on spending money for upstream challenges and changes?
Yeah, it's a good question, and I was sort of itching to actually answer. I think when that previous one was posed about why investment into upstream. I think that the part of the challenge with upstream, and you could equate this to, I guess, a political cycle, but the fiscal impact, positive fiscal impact of upstream investment doesn't show up for quite some time. So, we can talk about, for example, if we invested in early intervention and prevention, that we would see less people. So for example, one of the pieces of data that we looked at is the number of youth and children presenting at emergency department with mental health or addictions issues has risen quite significantly in the last 10 years. So we know there is more and more pressure on the downstream acute system. The challenge is any sort of savings or cost avoidance that you would have by investing in intervention and prevention now sort of shows up quite further down in the fiscal cycle. And so when the public is demanding of government to be doing things like running a balanced budget or being at least economically and fiscally prudent, that's a challenging business case to make, I think. So you could attach it to political cycles. I don't know that it's just about political cycles. I think it's about the fact that we don't see the fiscal benefit of those upstream investments, even though we all know it makes sound sense to do that. You don't see the benefits of that until later down the road. And unfortunately, also the acute system does seem to just eat up the extra dollars anyways, even if you have less people going into emergency department. And I guess the last thing I'll say is it's interesting to me. I think there was a World Health Organization study that was done at some point, and they came up with some notional percentage. I think it's 10% of your healthcare budget or something like that, or it might be 80%. Should be aimed at early intervention and prevention. And so there's that floats around as well. And if you think about that, that's not a lot of money to invest in that, especially when you talk about the things that Trevor was talking about in terms of even further upstream, like and social determinants of health. So when you talk about housing, when you talk about poverty reduction and all of those things, so it's very curious to me that the World Health Organization came out with that number, because in my mind it didn't seem like a lot.
So we have a few speaker-specific questions, and then I'd like to get into some more general discussion. So this first question is for Trevor. Do you support, promote the health in all policy approach, or is there a better way or approach to get communities working together on non-health related issues that will ultimately impact health?
Well, thank you. Yes, I definitely support the health in all policies approach. That is what is meant by a whole of government approach, although recognizing it also needs to be whole of society. I think, though, that the problem in that, and that's why I made the point with one of my slides, that really the Minister of Mental Wellbeing is the Cabinet and is the Premier and is the whole of government. That it's not the responsibility of Nailane's ministry to improve the mental well-being just on their own. There's a piece that they do, but it's actually a relatively small piece. But also her point about the challenging fiscal situation, making the argument that, well, you spend the money now, but you don't see the savings for years, or the savings, we spend the money in healthcare and the savings accrue in housing, or vice versa. I recognize that is often the attitude that is there. It speaks to the wider issue I talked about earlier, that we need to be challenging some fundamental assumptions. So first of all, the outcome of, I always used to argue this for public health, our purpose is not to save money. Our purpose is to save lives. And we may or may not save money in doing that, but we don't expect an intensive care unit to save money. Why would we expect public health to save money? What we can argue is that that's a more cost-effective intervention in terms of number of lives saved per dollar invested to go into public health. But public health, it's really the population interventions you need, the housing and all the other things that we've talked about all afternoon. And so we need to be doing things such as for example, I think I mentioned it, but the New Zealand wellbeing budget. If you look at the wellbeing budget in New Zealand, they had 5 priorities. 3 of those priorities, I'll read them to you, were lifting Maori and Pacific income skills and opportunities and incomes, reducing child poverty and improving child well-being, and supporting mental well-being for all New Zealanders. That was in their budget. Those were their budget priorities. So you start to get very different answers if you start to put people first and then look at where do you best need to spend the money. And you may not need to spend it in healthcare at all. There's a good argument to be made that you should take a chunk of the healthcare budget and move it into things such as social prescribing, things such as housing and education and so on. Just as it's actually quite analogous to the argument we're having around quote unquote defunding the police. No one wants to take all the money away from the police, but is there money that is currently and resources being used by the police that will be much better, more effectively used over here in social services of some sort or in education or whatever it may be? So you need to take a comprehensive approach and not be tied down to how much money does it save next year. The work we're doing doesn't save money next year.
Well, and that takes us perfectly into a question from Amelia, who says, "Hi, Anna, very impactful presentation. Do you think it would have been helpful for you back when the police came if there would have been a mental health clinician attending with the police officer?"
Thank you so much, Amelia. Yes, the short answer is yes, I think so. And again, I think I was unfairly lucky in that regard. I wasn't manhandled, I wasn't dragged away, but I was very afraid. And there were these 2 armed uniformed cops in my apartment in the middle of the night. I didn't know what to tell them. I think it's very possible, and again, obviously I'm speaking in hypotheticals, but I think it's very possible that had it been a peer worker, had it been a crisis worker who looked like me, who was just saying like, "Hey, how's it going? I hear you're having a rough time. Do you want to talk about it?" I might have been more, and again, I had no experience talking about, my mental health. I had no experience talking about wanting to die. So that might have made me feel more comfortable discussing what seemed like a really shameful thing to me at the time. As it was, I didn't feel comfortable obviously the cops didn't talk to me. I didn't feel comfortable talking to the psychiatrist in the crisis ward. So I just got discharged long enough to attempt suicide. Now, again, the outcome of that was that, I didn't die. But I think the outcome of the police visit could have been, or that crisis visit could have been different had there been someone else at the door when I opened it.
Okay, Tyler, the next question is for you. Currently, this is from Linda. Currently, mental health problems are generally seen as a medical problem. Some have challenged this and feel it might be better viewed as a social problem. What are your thoughts on this? And what value might there be in changing how we see it in terms of our approaches and solutions?
First of all, thank you for the question, and I've been so enjoying this dialogue. I think we need to, first of all, respect the varied experiences that people have when we talk about mental health or addiction challenges or suicidal ideation, to name those who are experiencing serious mental illness and their caregivers, and ensure that we're respecting a diversity of experiences when we talk about, is it social, is it clinical, and what happens. I think, as has been talked about today, we need to make sure we have a special focus on those with serious mental illness and ensure that housing, safe environments, whatever is needed is provided. And that's an important part of our community family. But when you think more broadly about what's driving the kind of higher rates of anxiety and depression and people falling back on their addiction, and what's going on more broadly, particularly as COVID reveals these system failures and the racial disparity, we start looking at these broader social factors that are really what's going on, and that we don't want to clinicalize those. There may be clinical or medical moments where care is needed. But I think what we're talking about in, for example, with even the workforce conversation is about how are we having our needs met in community, whether that's supportive environments in the first place, where the social determinants, or we've been talking about in the United States, these vital conditions for intergenerational well-being, where they're intact. Those are environments for human flourishing. In the public health arena, we talk about that as health promotion. Then there's a whole array of prevention elements that are needed, and we've been talking about them. And then there's moments where care is needed. But I want to build, if I could, on the beautiful conversation that starts about defund the police. When we task shift jobs to people with lived experience and training as peers, as community health workers, where that lived experience becomes a gift to be contributed back to the communities, we actually expand care, but not in the clinical way, to the great question that's asked, but the human connection through lived experience and listening. Anna, you're people who talked about who else could have come to your door, someone who might have listened and met you where you are. I think there's an extraordinary opportunity to move many of those kinds of services into the community, whether it's through police, social services, or other visits, that actually center care in caring in communities, with culture setting the tone for what that looks like. And in the meantime, shifting the money from bigger institutions into community and local jobs, designed locally in ways that match the local community. And then you have the opportunity for the diversity of expression and adaptation of initiatives that matches the diversity of our communities and how they want to think and work and operate.
So would anyone like to build on that?
So a couple of thoughts. One is, of course, the person who wrote the book on this 40 or so years ago was Ivan Illich, who wrote Medical Nemesis. And what he talked about was social and cultural iatrogenesis, the doctor-induced diseases, because we medicalize social events, we medicalize cultural events such as birth and death, and the medical profession takes over. And that's part of the problem with them. So it has these profound social and cultural impacts. A wonderful story about this that I learned and sort of cut my teeth on more than 40 years ago. John McKnight, who Tyler knows well, and many of you probably know well, had a strong interest in mental health, incidentally, and in disabilities. He wrote an article back in about 1978 called Politicizing Healthcare, which is the story of how one community took charge of its health issues. And it's the sort of thing you actually see in First Nations these days in particular. Took charge of its health issues and said, no, these really are not medical problems that can be treated by medicine. It's community problems that we can manage. And so those sorts of interventions are really important. But part of it means the medical profession has to back off and say, actually, no, that's not our job, not our expertise, not our resources. And I gave a talk a couple of years ago to a group here in BC, a medical group that was about, I forget what it's called now, but it's sort of specialist GP collaboration. And I said, part of what you have to do, if what I'm saying is right, is give up some money and give up some resources to others who can do the job better.
Anna, you had a comment.
Yeah, and I just want to apologize for my dog who thinks he's a bit of a guard dog. But I agree absolutely. And I think it's not a question of either or. We need to treat them as such if we're going to resource them, if we're going to treat them the way we treat other illnesses. But I think we also need to recognize that they are the products and they are exacerbated by social issues. And that's true of other medical problems as well. I mean, we see cancer and cardiovascular illnesses, certainly COVID. We see higher prevalence of COVID among communities of color, not because communities of color are these issues of systemic biases, make them more vulnerable, make them more likely to have this illness and to have worse outcomes. So we need to it's important that we recognize mental illnesses as illnesses. It's important that we resource the medical care that's necessary. But it's equally important that we recognize, that there are, as has been so eloquently displayed here, upstream can exacerbate the likelihood of bad outcomes that we need to address. So I think it's absolutely both.
Yeah, thank you, Anna, for that, because I think it's I don't want it to be a we need to put everything into early intervention and prevention and then not actually make sure that we've got adequate resources and services and supports for those that are dealing with serious mental illnesses, because we often we talk about the fact that within the healthcare system, mental health is sort of the poor second cousin to physical health, and then addictions is the poor second cousin to mental health, and so we do not have parity or equity in funding or investment, even within the healthcare system as a whole. And so I always worry a little bit when we talk so much about and I absolutely fundamentally agree, upstream investment and upstream focus is absolutely important, but it can't be a one or the other, because we do know that the existing healthcare system, there are significant disparities, there are inequities, there are systemic biases, there is culturally, unsafe services, there is discrimination, there is all of those things. And so we can't, I don't want to let the healthcare system off the hook, so to speak, by not reflecting on the fact that we do need to make sure that there is focus both from an investment perspective, but also on ensuring that the system is addressing those systemic biases, those systemic barriers, those things that are making it incredibly difficult for a wide range of vulnerable people from accessing services that they need.
So Nicholas, what questions would you have for these amazing folks?
Thank you to all the presenters. Wonderful presentation. Going back to kind of some of the previous questions around COVID and the opportunities and challenges, I'm wondering, in this heightened awareness of mental health, when we have seen increased investment in things like virtual health, and knowing that there are barriers to virtual health around connectivity and et cetera, but I'm wondering if each presenter could answer, what do you see as the opportunities during this time for investment in mental health, and then potentially what are some of the challenges? And I'm thinking about, in particular, Trevor and Tyler's presentation around, the return to nature and the importance of nature in terms of mental health and well-being. So what would you say are the kind of key opportunities and challenges during this time?
I think that one of the things that we've learned from COVID is the importance of community and the importance of connection, and how bad it is to be isolated. And so if you take that and apply it more generally, notions such as social prescribing that I mentioned earlier that are starting in Britain, and much more broadly than that, we've just had a report here on economic recovery for the Greater Victoria region, and it's called Reboot, but it's all about the economy. And so I want to work with some folks now to do a parallel report called Rebooting the Social Sector, because we've underinvested in the social sector for a long time, and not just the social sector in the sense of providing services, but in libraries, in recreational centers, in community organizations. One of my board members for the NGO that I've set up here talks a great deal about the fact that who funds the people who make the connections, who are the community facilitators? And nobody really does. But that's an important job, and it does need funding. So I think we can learn from lessons from that about how important those connections are, and the simple ways to do that, social prescribing being one of them, where really you're having what they call in the UK a link worker who links people to local groups and organizations that might be compatible with their interests. One of my favorite examples, which came out of Australia, is men's sheds, which is exactly what they sound like. They were sheds that were set up and given some basic tools and a coffee pot, and it's where the retired men, who are usually more so at a loose end than women because they're less good at making social networks other than at work, where they would go when they were retired and at a loose end. And, they'd end up fixing kids' bikes or sending groups out to fix up the homes of people who couldn't afford it, or didn't really matter what they did. It was actually a mental health program, but nobody ever called it a mental health program. So those are the kind of things that we need to be thinking about.
No, excellent response, Trevor. I'm aware of the mental health sheds, and for men in particular. So I think that's a great example. Others' thoughts on my question?
This is actually something that I've been wondering a lot myself, because I feel like it could really go either way. On the one hand, I think everybody's a lot more attuned to their health, period. But I think there's been a lot more scrutiny of mental health and the precariousness of mental health in an environment where we're all so isolated and we're all so anxious, frankly. So I think any increased attention by the average person to the importance of mental health and the risk of mental illness can only be good for the provision of resources and the adoption of initiatives to safeguard mental health and treat mental illness. On the other hand, I worry that just from a health system perspective, I think COVID has tended to kind of suck up all the energy in the room. I don't think we've quite ferreted out exactly who we've been missing from the drop in emergency room visits, for example, early on in the pandemic. So I don't think we really know exactly who wasn't going to hospital out of fear of COVID. But I worry that people aren't accessing acute care either because resources aren't there. I know I've been, on wait lists for services that have been cut off because of the pandemic.
Tyler, your comments.
I just want to lift up that I think I love what you said. COVID has sucked up so much energy. Of course, we have to deal with it. Our failure to deal with it fully is why we keep continuing. And we're seeing here in the United States, just as we going out through whole rounds because we didn't get it right the first time, and God willing. But underneath this is this unmasking of system failure and racial inequity and what has been seen, which, all of us on this call, and I'm sure everybody participating tonight, has probably spent much of their life contributing to try and improve these issues. We're all really trying to do that. For me, it's that we've been tinkering with half measures, an effort here, not the systems upstream all-in approach that has been talked about today. We need a whole system approach, all in. Even associated with some health systems in the United States, and we do our community benefit grant making. But how about our purchasing, our hiring, the investment portfolios, driving the local economy with the anchor institution role of healthcare and universities, spinning that local economy flywheel? That's what creates vitality, rather than just the healthcare systems making grants on the side of this. And this is the kind of, I think, all-in mindset that's needed. Then the team-based integrative primary care, Neilane, that you were talking about, and the clinical community integration that ensures that integrated care is connected to social prescriptions and the navigators and those local businesses, that is a virtuous system. And when those investments are made over time, like we raise a family, not for 2 or 3 or 4 years, but for a couple of decades, that long time community building, nation building, it was described earlier, I think, so beautifully. That attention to the long haul, to me, is what the teaching of COVID is, the opportunity of COVID is, to tell the truth and be all in.
couldn't agree more. Just wanting to focus in a little bit on what the Fresh Outlook Foundation, how we look at things, and sort of as a social learning, social change, behavior change type of organization. We know that these really tough community sustainability issues can only be best dealt with if people from all sectors, ages, cultures, abilities, and genders communicate and then collaborate around positive change. And that collaboration is important, not only because it's the right thing to do, which it is, but because people from different sectors, for example, bring different insights, ideas, passions, personalities, and influences to the table. And so my question is, in an ideal world where people from all walks of life are collaborating well, what does each of the sectors bring to the table? And Neilane, I'd like to start with you. I know that you're on the way to doing what you believe is best for BC, but in an ideal world, what would government's role be in this process?
Trying to figure out which hat to put on. Well, I think that, we have to remember that there's a couple of roles that government as a whole fulfills. So, there is a big arm of government, obviously, or multiple arms of government that is involved in the delivery of programs, services, and supports. And so, fundamentally, there's a key role there. And I think, I appreciate Trevor's comment with respect to, that it's not just our ministry that can do this, and I wholeheartedly agree. And I've talked about this a little bit in not with this group, but for much time now, even in previous roles, that the structures of government are work against collaboration sometimes and work against integration, because fundamentally we end up structured as ministries, and we can all work very hard to try and work collaboratively, but there's just some fundamental structures that are there that are just part of a democracy and part of the way that can't go away. And so working as a whole of government is challenging, but I think that that's a challenge that is the responsibility of government and the responsibility of cabinet, and they do need to come together, and then we need to come together as public servants at the deputy level to be doing what needs to be done to make sure services and supports are aimed at the right things, they're being delivered in an integrated way, and that we are supporting the right kinds of investments into upstream, et cetera. But I also think that government can be an enabler. Government can be a prompter. Like we can set overall a tone and tenor for what is expected within the jurisdiction, and that doesn't sometimes it comes through laws and legislation, but not always. Sometimes it comes through, and we pushed really, really hard just to get the strategy out, because we felt like getting the strategy out would in and of itself just set a tone and tenor and a vision and so I think that we have that service delivery and the working together and trying to make all that kind of stuff, but I also think that government has to model in what it talks about, model in what we say publicly, find the ways to enable the kinds of whole system, everybody in it together kind of approach that's necessary to make the kinds of changes and to ultimately change views and behaviors and expectations of citizens.
Yeah. Nicholas, I know that the Mental Health Commission of Canada, a chunk of the work you do is research-based. So can you just share with us your thoughts about the role of not only research, but then getting the word out about the research that people can actually work with to make changes on the ground?
Yeah, such an excellent question, Joe. I think a big part of the Commission's work in early days, and for those who don't know, the Commission started in 2007, was research-based. But I think as an organization, we've really shifted from just doing, research to doing research and then demonstrating the applicability and the benefits of that research. So there's a few examples of that. I think, our Roots of Hope project, which is a suicide community prevention project, which is really research-based, but then takes the research and applies it to community settings to ensure that communities, and we've talked about communities a lot today, come together with a collective approach to, looking at mental health and working towards, positive benefits. Our Steps Care 2.0, which is a mixed e-mental health and system transformation approach, does the same thing. So I think, research is fundamental to changing the landscape in mental health. But what is so important that goes along with that research is a good knowledge translation strategy. It takes 14 to 16 years on average for research to get into practice. But if you apply these principles of implementation and knowledge translation and actually test what you're doing, in a safe and effective way, I think the outcomes can be so beneficial to society. And there's many examples of that.
So, Trevor, what about the role of the mental health care system in general and public health and physicians in particular?
Well, apart from their role in providing services, and Tyler talked about that of course is a fundamental role, they need also to be advocates, both within government and beyond government. And that's not easy for ministries to do. I recognize that. And nor is it easy for the healthcare system. I used to say when I worked with hospitals that I would believe hospitals were serious about health promotion when I heard them speaking out publicly about poverty and health, because every day they saw the impacts of poverty on health carried through their doors, but they very seldom, if ever, spoke out about it, and they should have. It was actually, I wrote an editorial for the Canadian Journal of Public Health a few years ago, and it was called "Advocacy is not a dirty word, it's a duty." And it's got to be seen as a duty. It's actually considered one of the 7 or 9 fundamental skills for being a physician. If you look at the CanMed's sort of framework, it's considered an ethical duty in the CMA Code of Ethics. It's considered a core skill for public health professionals in Canada's public health competencies. So it is part of our job to be advocates. And I just gave a talk to a group of medical students, Ontario Medical Students Association last week, about exactly this, that it's their job to be advocates, not for just their patients, although they should be, and not just for their profession, although they should be, but for the population as a whole and the health of the population. Yes. So it is the Minister of Mental Health and Addiction's job to go to Cabinet and say, sorry, folks, the business of government is not simply about business and the economy. The business of government is about people. Tyler mentioned Jim Roust's comment. It was actually design instructions to his design team when he was building a community called Columbia in Maryland. And his instructions were, build me a garden to grow people in. The business of government should be growing people. It should be maximizing human and social development within a sustainable ecological context. And the economy is simply a tool we use to do that. So instead of people serving the economy has to serve people. And that's the Minister of Mental Health and Addiction's job, the Minister of Health's job. It's everybody's job to be saying that. We need some very fundamental shifts in what business we're in, what it is we're trying to achieve here. And I wouldn't say forget the economy, but relegate the economy to being the tool it should be, not the dominant force that it has become.
So, Tyler, my question to you is about the role of nonprofit organizations or civil society, and I know that varies from organization to organization. For example, the Fresh Outlook Foundation, we don't take sides on these issues other than, of course, we are pro-sustainability, but we like to engage in neutral, nonpartisan discussions with people about these issues. Now, I know that your mandate is much more focused and much more goal-oriented. So maybe just share what you feel the ideal role of an organization like yours is in this movement toward better mental health care.
I really appreciate the question about kind of what's the underlying role. I just want to pivot that off of what Trevor was just talking about the role of government to care for public welfare, to care for the common weal, if you will, the welfare of people and what actually gives rise to flourishing in that way. So most of my work, which has included hundreds of communities, has come out of what I would call local democracy, which is the bringing together of residents of communities with business, with nonprofit, with local government, with the faith community, with the diversity of our communities together, using our democracy to inform each other's discretion, make wise choices, and build the public will to advance it, which to me is built in trust. That's why I want to go back to link what is so fundamental about this, and our Indigenous wisdom earlier was speaking to this. When we remember who we are as human beings, we both bring our vulnerability and tenderness to each other. And that's part of what's needed right now, is caring for one another as ourselves. But when we pivot that same goodness, if you will, to the public sphere, we want to serve. And when human beings serve, we know that our sense of belonging is built. We know that our service gives us a sense of purpose, all of which are health promoting, well-being promoting factors. So a civil society like that is key. So a philanthropy, to answer your question, a philanthropy's role then is to help cultivate that and to seed invest or de-risk promising initiatives to create proof points, because we can do that with private and nonprofit capital to de-risk that, which then can be moved over to the public sphere. And then with the evidence, then Neilane and her colleagues have confidence that they can put their weight of government behind that. So we really see that as is building civil society sufficient to understanding and investing, de-risking through the use of capital, and bring that into broader world.
I just want to actually just pick up on what Tyler said, because it is critically important. And there are some of the initiatives, for example, the Foundry Initiative that I referenced, it actually originated, outside of government as a thought and as an innovation, and they actually got and they still to this day rely sometimes on philanthropic dollars to actually do some of the startup costs in terms of capital improvements. And we have other examples of that where there is innovation that happens outside of government. And that's why I say it does require all of it. It requires everybody, because there are things that are more difficult for government to wade into, but when they become it comes clear from an evidence-based perspective, and there are lots of other examples beyond the Foundry that I could reference, but that then government does then begin to either take it over or invest or partner in those innovations. And so there's a role for everybody, I think, and but what's critically important to get the kind of systemic change that we want is that there kind of needs to be that sort of cohesive clarity around what are we trying to do and where are we trying to go and what kind of change are we trying to elicit. Because if we're all if the whole of society is operating with different visions, and then we're not going to end up, I think, being able to make the kind of systemic change that we all are talking about today.
Now, my last question for this panel discussion is for Anna. And when we talk about the role of people from different sectors and ages and cultures and whatever, I think we're just now starting to realize the critically important role that people with lived experience have in this discussion. And to that end, 4 or 5 of the presenters that we have during this session, including Anna, and moving forward, are people who have experienced horrendous abuse at the hands of the mental health care system. And but despite that, they have come out the other side, and they are working to help build a better mental health care system, to help people in their spheres of influence who are struggling. And I find that resilience just so incredibly heartwarming and just such a blessing to us all moving forward. So Anna, first of all, thank you again for your vulnerability, for sharing your story. And I'd like you to just close off this panel discussion with your thoughts on the role of people like yourself who have lived experience with mental illness.
First of all, thank you so much for involving me. It's been such a pleasure and such a privilege to be a part of this. So thank you who've been there, people who have lived experience, which is not to say, I mean, empathy, I think, is one of the most valuable attributes out there. And I think anybody is capable of it. So I think it's vital for practitioners to have empathy. I think it's vital for policymakers to have empathy, for researchers, for people who are blazing the trail from the private sector. But I think it's so critical for us to listen to the people who have been there, because these aren't things that we've talked about. Very, very few people know what it's like to have it feel like your world is collapsing, whether it's because you're hearing voices, because you want to kill yourself, because you can't get out of bed, because you're cycling between these stages where you can do everything and then all of a sudden you can do nothing. And for millennia, we've, and again, I hate this word, but we've stigmatized these people to the point where we don't listen to them. We disregard their voices. Even recently, for example, even with people in the mental health sphere, I was working on an article about ECT, and I would mention that I was still recovering from ECT myself. And there would kind of be this, all of a sudden, the talk would get really cold, because people don't trust people with mental illness. You don't trust them as to tell their own stories. You don't trust them as, reliable narrators or reliable observers. And I think, while we need to obviously acknowledge that some of these symptoms include difficulties grasping reality, I think we need to really embrace these narratives and these stories as vital to our attempts to create a system where mental illness is not debilitating, where it's not something that ruins your life, where it's something that you can live with and something where you can enter remission from. And I think that's crucial. So again, I don't think that only people with lived experience can set the stage or can blaze these trails, but I think they're an absolutely vital part of the work that we need to do.